This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 648, recorded on July 31st, 2020. I'm Vincent Dracaniello, and you're listening to the podcast all about viruses. Joining me today from New York State, Daniel Griffin.
Hello, everybody.
And also from New York State, Chuck Knirsch.
Hi, Vincent. Hi, Daniel.
Welcome back, everyone. Time for our weekly update, and the weeks seem to shoot by. July is almost over. How about that?
This is true. You know, I was just thinking, Chuck, when I go sailing tonight, I can probably see your house.
It's dark outside. Are you going to maybe have some rough weather out there?
What, you go on the Sound or something? Is that how?
We do. We go out into the Sound, and sometimes it can get a little exciting out there.
I'm sure. It's a good way to get away from COVID for a while, right?
It's important.
All right.
So I have a couple quotations here. I heard people enjoyed the quotation last week. Apparently, we're going to be making a T-shirt. Masks are cool.
Yep,
the doctor. So some people got the reference there. So here are my quotations this week. Headlines, in a way, are what mislead you because bad news is a headline and gradual improvement is not.
That's so right.
And that's from Bill Gates.
It's true.
Who is?
I often ask journalists, why don't you report this or that? And they say, it's not news.
And the other is, I'd rather get bad news from an honest man than lies from a flatterer. And that is Ursula K. Le Guin.
Oh, right. The writer. Huh? Yeah.
Yes.
Nice.
Big fan of her stuff. So let's, I sort of put those out there because I was having a conversation in the intensive care unit yesterday, and it was with one of the emergency room physicians. And his comment after we talked for a while was, Dan, that is the first good news you've given me, well, since February. So apparently I have a reputation for lots of bad news. All right. So we'll start off with bad news. Case numbers, deaths, morbidity, we're not doing well as a country. We're not doing well as a world, actually. We're back up to over 1,400 COVID deaths per day. And that's more than a death every single minute. So just think about how many minutes you listen to this podcast. Every minute another person in the United States is dying. I mean, this is a disaster. People talk about things plateauing. That's not an okay plateau in my mind. And how are we going to get on top of this? So the last TWiV just before was testing our way out of the crisis. And so I'm going to talk a little bit about, quite a bit about testing, actually. And this has been a challenge. Actually, I got a call yesterday from Lawrence Shulman. He's the head of our COVID core team at ProHealth New York. And we're now ramping up our ability to do testing. And one of the things we're running into is even though maybe the public has lost their fear of COVID, healthcare workers haven't. So now that we can do more testing, there's a lot of offices that really, they basically the signage is we don't want COVID patients here, right? So as soon as you say, hey, we're going to start doing these rapid tests, we want to be able to find out who has this or not. A lot of the people in the office are scared. They're basically like, well, can't we do that? Can't we keep them outside? Can't we just leave them in their cars, etc.? So I'm going to talk a little bit about the transmission and testing and how this works. So I always think repetition is important. So we know that those people who show symptoms, that they actually start to become RNA positive 2 to 3 days prior to the onset of symptoms. So 2 to 3 days, 2.4 is actually the number out there. They are RNA positive, actually at higher levels than when you test them the day they come in with symptoms, right? So these are some studies that we've got now. So that's going on. Are they transmitting as much? I think this is sort of an interesting issue for case control studies. If the nose isn't running, if they're not coughing and sneezing, they may have a lot of RNA in their nasopharynx, but there's a question how much they're sort of spraying out into the environment. Once there's an onset of symptoms in the large percentage of people with normal immune systems who are able to stay out of the hospital, we say it's 5 to 9 days after onset of symptoms that they're remaining PCR positive at a rate high enough that we think that they're infectious. I'm going to hit on what is that RNA level that correlates with infectiousness. So this gives us a window, right, as we're talking about from 7, as short as 7 days. I think Michael Mina sort of hit a 7, but maybe out as far as 12 in some of those individuals, right? We've actually cultured it out to 9 days. And contact tracing, I think, goes along with that. And the WHO and CDC, they actually push back and they start looking at people that you were exposed to 4 days prior to the onset of symptoms. But let's say you've got this 7 to 12 day infectiousness window. Now, we think the same period of infectiousness applies to asymptomatic individuals because we know a certain number of individuals become PCR positive at high levels, but never, ever show any symptoms that we would attribute to COVID-19, to the SARS-CoV-2 virus. But there's a little bit more uncertainty there. We just don't have the same amount of data that we have in the symptomatic. Now, in severe cases, people with immunosuppression, people who are hospitalized, those treated with immunomodulators, those are the steroids, the IL-6 receptor inhibitors we talk about. The infectiousness may extend out to 20 days or even longer past the onset of symptoms. So that's where the CDC guidance is. That's where you need to start considering test-based approaches to address those people, the involvement of an infectious disease specialist or an infection control specialist. But let's talk a little bit about RNA levels and infectiousness. And I've created a little table here. And I was sort of glad I created this table because I keep getting asked this question. And so we're really, in my table, I have 1, 2, 3, 4, 5 levels. And so the very low level is an RNA load or an RNA piece number of about 100 or less. And that's that sensitivity of our nucleic acid amplification test, our PCR, RT-PCR. We get up to an RNA load of about 1,000, and that's CT values of about 36. So maybe people are getting a little familiar with CT values. But then an RNA load of about 4,000 or 5,000, and that's when we have a CT number of 34, if we can ever get access to those CT numbers, which we've talked about. And that's where our Abbott ID now picks them up. So 4,000, you're not even infectious yet. And I know we talk a lot about sensitivity of tests, but in that seminal publication out of NYU, if you had more than 4,000 pieces of RNA, the Abbott ID now was 100% sensitive. So I think when we talk about these quick, inexpensive, cheap tests that lack sensitivity, I'm going to sort of challenge the concept of sensitivity. Sensitivity for someone who had virus 2 weeks ago when we were just picking up the tail, that's different than sensitivity for infectiousness. You get up to an RNA load of 50,000 or a CT value of about 30 on our RT-PCR. And these would be all those rapid antigen tests that Michael Mina is talking about, that the Broad Institute is hopefully going to be helping the Boston schools use to get everyone tested. The rapid antigen tests such as BD, Quidel, OraSure, all these ones that, at this point, we're not down to the $1 a test price point, but we're moving rapidly there. If you have an RNA load of 50,000 or more, these tests are picking it up. Mm-hmm. You don't really become infectious until a CT value of about 24. That's 3 million. That's a lot. So the sensitivity of these cheap, rapid tests for picking up someone who is infectious, they're great. They're not really inferior tests. So I just want to sort of make that out there. What does it take to get sick with COVID-19? And this is, I know, a concern that our nurses, our office staff, if you bring a person into an exam room, they sit down, they're wearing a mask, you put a Q-tip in the nose, you pop that in the vial, they walk right back out, minimal contact time, you're wearing a mask and eye protection. We don't consider that a significant exposure. That's not where we're seeing transmission. We're seeing transmission when you're sitting within 6 feet of someone, they don't have a mask, you don't have a mask, no one's got eye protection, and you're talking for 15 or more minutes. So this is not radiation, right?
Probably especially indoors, right, Daniel?
Yeah, exactly. Outdoors, right? Outdoors, it seems like it takes even more exposure.
Right.
So, in an ideal world, we're doing this in the cars, rapid, people are swabbing themselves, etc. But, we're all going to benefit by testing, tracing, identifying these people. So, just sort of to reassure that this is not measles, right? Where someone walks through on the way to the exam room and, well, we're all sick. This actually takes a certain exposure. And I think we've learned more and more about how much exposure that really is. So I like to use my slide analogy when I tell people about this whole infectious thing. Think about going up the slide. Like when you're standing there and you get onto the first rung, even if you slip, you're going to be okay because that's such low level of virus that you're not contagious. When you're getting there up about halfway to up the top of the slide, that's when you're getting into the millions, when people are at risk, when, if you're the mom or the dad, stand there, don't let the child fall off the slide. That's also the time when we don't want this person going to work. We don't want the person out there spreading virus. When they start coming down the slide, still, they're up there, want them falling off either side. Once they get to the bottom of the slide, we're okay again. So sort of think about that as far as exposure and the infectiousness.
Daniel, these numbers, does it make a difference if you're symptomatic or asymptomatic throughout the entire course of infection?
So it doesn't seem to. When you look at, I know Anthony Fauci made the point of, hey, if you're above 35, the chance of spreading disease is minuscule. And that was based on one study, right, where they actually were able to culture virus from someone who was at 35. But in general, if you look at the transmission studies and the other studies, unless you're more virus, unless you're coming up before 24, you're not spreading. And, we know a lot more, I think, about people who are contagious. But now as we get more and more data, I think this probably is the same for people who are asymptomatic as well.
Yeah, it must be because we know a lot of transmission occurs from asymptomatic people, right?
Yeah. Unfortunately, right? It would make this disease a lot easier if you could eyeball people with symptoms. I was doing a talk today on fever, and only a quarter of people, with COVID-19 who are spreading, we think, ever even get a fever, right? I mean, the people who get symptomatic, it's not everyone. And then the asymptomatic people, they don't get fevers by definition. So,
yeah, a lot of schools want to do fever checks, and I'm not sure it's worth it. A lot of them are going to buy equipment, and it's not going to pick up, and it's even less penetrant in children, I think, the fever compared with adults.
No, you're correct. And I think that we've seen that children are seemingly less likely to show symptoms. So if you're going to be looking at schools, if you're going to be opening things up, testing is how you know. I mean, I remember early on, it was actually the early days of March, and it was the chief of medicine of Plainview. And he was asking like, oh, well, what about the procalcitonin? What about this test? And I was like, oh, actually, you know what test seems to correlate with COVID? The PCR. So I was like, we actually have a test. And that's how you tell if someone is shedding virus. You do a COVID test. I was on a call Tuesday night with one of the large media production companies, and they basically were saying, we want to open. And again, if we want to open, how often do we have to test? And who do we have to test? And I said, well, if you really want this to work, you're going to test everyone every morning before they go to work. And and I even laid out and I said, and this is how much it's going to cost. And basically they said, okay, that's what we're going to do. And I love those conversations where people get it. If you want to do this, it's going to cost a certain amount of money. Maybe right now that'll be $30 a day, but very soon that'll be $10. And before we know it, we know we can get that down to $1 or $2. And $1 or $2 to open up the economy per person, that's not even a cup of coffee at Starbucks. Maybe people are listening in other parts of the world and they don't know how much we pay for a cup of coffee at Starbucks. But we can do this. We can test ourselves out of this crisis. We can safely open schools. But yeah, as I think we're sort of hammering in here, testing is how we
unfortunately,
we
many
can
schools
safely open when there's low transmission. I think in the areas, and why our friend Peter Hotez wrote to the Wall Street Journal, probably more drastic measures. I don't know about full shutdown. Vincent, you were debating that, I think, in the last TWiV a bit. But some measures, you need to bring the level of viral transmission down before testing and tracing and contact will be helpful. But I think it could open the schools, especially in New England, New York, New Jersey, Connecticut right now, where we have, flattened the curve, so to speak.
Yeah, I think many schools do not have the ability to test, Daniel, and so they're not. And it's unfortunate because they should. It should be cheap enough that they could do it, because that's really the key, as we've been saying.
Yeah, interesting enough, you say that, but it is basically no cost to get a COVID test, right? And so that was sort of that conversation is, it is supposed to be the deal that with all the federal government support, which is now seems like there's a little bit of a waffle here. But when you go get a COVID test, it's not supposed to be a cost to you. This is something that the insurers, et cetera, are supposed to cover. No co-pays. You're supposed to be able to go get tested without a cost to you. So it isn't even $1 a day. This is what our government is supposedly providing for us. So I think a lot of us. There was actually, I think I may have mentioned on the last TWiV where it was Quest or LabCorp had sent out an email. Not only will we partner with you to do testing, but by the way, we'll also do sexually transmitted infection testing at the same time, which I thought was interesting. So. Yeah,
public health campaign.
Yeah, let's not just give up. Let's demand that, if we're going to say let's open the schools, let's demand that we do it in a way that's safe for our children and for our teachers and for our communities. Vince and I, we were talking right before another study coming out. Maybe kids are not less likely to transmit than adults. Maybe they're even more. So this is concerning. And I know I did a tri-state urgent care talk the other day. I talked about the urgent care centers, and I talked about what tests we need in those settings. And so really similar to just echo what I just said. If someone comes in and they're sick and they don't feel well and they're thinking it might be COVID-19, one of these rapid tests will tell you if it is or not, because during the acute onset of illness, you're going to have very high levels. If the person says, I'm going to be, in a situation where I might expose someone at risk, the rapid tests are going to tell you if you're infectious. If you were sick 2 weeks ago or 10 days ago, and now you're having shortness of breath and we're worried that you're getting into that cytokine storm phase, okay, that's where you need the RT-PCR. That's where you need a more sensitive test, because now you're not suffering from a high viral load. You're suffering from this immunological issue. So different tests, but you know what? The expensive ones are not the ones we need in most circumstances. Masks. So there's actually some more stuff coming out about masks. So, where do masks play a role? The nice thing I thought about this recent article I saw is, so we've been telling people wear masks to protect your neighbors. I'm not sure how altruistic we all are. So it was really nice to see a study. Masks do more than protect others during COVID-19. This was actually an article looking at masks reducing your risk of getting COVID-19. I think it's nice. Maybe there's a little evidence that not only are you doing the right thing by your neighbor, but you yourself might benefit from wearing a mask. So not only are masks cool, but they might be something that helps you as well as helping others. But I was going to talk a little bit about the public health perspective we as physicians are being pushed into. We're role models now. And I was at a meeting a couple weeks ago, and there were a lot of clinicians in this room. And actually, it was only a couple of us that were actually wearing masks. I was one of them. So that's an issue, right? You got to think about that. But I'm going to say, let's not mask shame each other. Let's think about how to wear masks properly, because this is not a sprint. This is a marathon. When you're with your wife, when you're with your social cohort that you might be sitting together in the home, limiting your exposures, watching TV. If you're now sitting on the back deck, or you go for a walk and it's just you and you're able to avoid others, it's the same outdoors. Maybe it's even safer outdoors than it was sitting in the living room watching Doctor Who on the BBC. But when you're not able to maintain that social distance and you're going to be within 6 feet of others, then you got to wear the mask. And one of the things I've been pushing for a while is this concept of these social cohorts. Some people use the term social bubble. I sort of don't like the baggage of a social bubble. I think it carries some interesting social connotations that maybe emailers will write about. But the idea of it looks now about 50% of Americans have adopted this, where two families might decide we're going to be a social cohort or form this bubble, as they say. A lot of times it's based around the children, because it is really important to have those social interactions. But I do want to remind people that it's not like, Kevin Bacon and 6 degrees of separation. That social cohort has to be of a certain size. You can't then have a social cohort that becomes your entire town, because then it ceases to be a social cohort. But these are important. And interesting enough, that is a nonpartisan issue. They actually looked at people of different political affiliations, and it's 47-50% independent of who you might support in the 2020 upcoming election. So this is being embraced by about half of Americans, and I think there's a big mental health advantage to these social cohorts. Understanding the clinical phases. I'm going to very quickly go through this, but I sort of want the pre-symptomatic, the viral phase, the cytokine storm, the hypercoagulable. And a little later, I'm going to talk about the late hyperinflammatory phase, this multi-system inflammatory phase that we don't just see in children, but we see in adults. And then the long phase, or the tail phase. Couple articles came out, and I think a lot of this is helpful for reinforcing the validity of these symptoms. I see a lot of individuals, right? They call me and they say, I've been suffering, and just sort of discounted. And there was a MMWR publication that came out, Symptom Duration and Risk Factors for Delayed Return to Usual Health Among Outpatients, which is sort of a neglected COVID population. We focused a lot on hospitalized. And they actually, they looked at about a third of the individuals were over 50, which meant 2/3 were under the age of 50. So we're looking at younger individuals who still think that they're immortal and immune to all these maladies. And they actually looked at, in this study, individuals aged 18 to 34. And then they called them 2 to 3 weeks after, disease onset, saying, hey, are you back to all better? Are you feeling fine? And actually 1 in 5 said, no, I am not back to all better. So, I like to say with influenza, if you check about a month out, about 10% of people say they have residual symptoms. People sick enough to get hospitalized with COVID, it's only about 10% that say they're all better. So it's a reverse. 90% are still struggling. And what we're seeing, not just hospitalized patients, but even people that didn't end up in the hospital, there's a tail to COVID. An interesting thing about that tail is it can have this sort of second peak where they feel crummy, they get better. And then some people, it's sort of this week 4, they feel worse again. And I know, Vincent, you would ask me, like, when we do blood tests, what do we see? We actually often see the neutrophils go back up, the lymphocytes drop back down. We see inflammatory markers start to go up. There was a study looking at cardiovascular issues in patients who are sort of out a little bit. And they actually we looked at 100 patients that had recovered, right? These people that were supposed to be better. And when they looked at them, 78% of these people post-COVID had ongoing myocardial inflammation. And so there seems to be a late inflammatory sort of resurge. And I don't know what drives this. So we'll get John Udall. He's going to help us and tell us why this is happening. We often think of COVID as like, some animal that no one has ever seen before, but that's not true. There's a lot of immunology. There's a lot of virology that we know. Fortunately, we don't know as much as we would like to. We spend too much money on aircraft carriers and not enough on basic science. But this may be something that we can learn from other illnesses. But we got some good news and some bad news on therapeutics, right? It was an interesting inhaled treatment with interferon beta that came out. Very small numbers, so we'll see where that goes. We continue to have our evidence for pulmonary support. We had another trial, the Montefiore trial on steroids, but then we have a bit of negative news on tocilizumab or Actemra. And I think it's reasonable to discuss that here. This was looking at using IL-6 receptor blockade without steroids. And I've talked about this for a little while. We were talking about this in the ICU today. And in many ways, I was not surprised. What we were seeing, and actually there was a trial at Columbia where Justin Aaron was involved. When you seem to give tocilizumab, when you seem to do IL-6 receptor blockade on individuals without a steroid first, people seem to get better and then get worse. So in this study, they did not show a mortality benefit. They didn't show a improvement benefit. That was the primary outcome. Interesting enough, there was an 8-day shorter hospital duration with a p-value of 0.03, but that was not their primary endpoint, so we won't mention that. That's a little more impressive than the 3-day with remdesivir. But another reassuring thing out of that study was there was no significant increase in bacterial infections, which I know I was quite concerned with tocilizumab, because once you put them on it, you've suppressed the immune system for a month. So it was nice not to see negative, but maybe a little trend towards shortened hospital stay. But Chuck, do you want to jump in on that?
It's not published yet first, so I think that what I'd like to do is look at each component of the 7, ordinal scale to see what's going on. Because composite endpoints, when they don't all go in the same direction, and with this one you can't go in the same direction, you can get better, you can get worse. I want to see what's going on, because overall it was about 450 patients if you look at clinicaltrials.gov, and the p-values, but not the absolute numbers, are in the press release. So let's wait for the publication. I think with IL-6 therapies like this, the choice of a patient population will be critical for benefit. So I suspect, like the steroid situation with dexamethasone, that maybe the sicker patients will have more benefit than this population that really just had oxygenation deficits at the beginning of the study. So I'm guessing. I haven't seen the publication, but we should look at that carefully when it comes out.
Yeah, I'm curious to see also about, these therapies used in the context of they got steroids and then, progressed and then got tocilizumab. Because, I think our experience, like when this came out, we're like, yeah, that's what we would have expected. So I don't view this as, a negative for tocilizumab as much as, I don't think this is something you want to use monotherapy, or at least that this sort of confirms that impression we had early on. I don't know, Vincent, if you had a comment.
There were 2 previous studies on anti-IL-6 receptor antibodies before, right? And they didn't do well. There was an Italian study and another one with a different antibody. So is it the case that in none of these they're using steroids? You think that's the issue?
Yeah. So most of them are not using steroids. There was an article. I should probably share this with you guys. It was by Ramiro, and it was where they basically, and a lot of the challenge, a lot of these are sort of historically controlled, right? Where we did this and then we did this and then people did better. But when people weren't doing well, we didn't really know about proning and anticoagulation, and where they actually did the steroids with and without tocilizumab. So it was tocilizumab within this context. And there they showed a pretty significant reduction in people going on to require ventilatory support. So I'm still curious to see where tocilizumab fits in the context, a background of steroids first, because what we see is when we give the tocilizumab without steroids, that IL-6 just shoots up, and it might go from being in the 40s to maybe over 3,000. I mean, it really goes up if you haven't done something, because you're blocking the receptor, which is going to create this feedback loop. So it seems to me a problem if you don't somehow shut down that feedback loop.
Okay. So you still have some.
We were emailing earlier today just that the factorial design of the recovery study, the Oxford study, has a primary randomization to the therapeutics, followed by, if you meet certain criteria, either tocilizumab or placebo. So I think that might help, because Daniel, you were saying, months ago that the pretreatment with steroids, and then IL-6 treatment seemed to be working anecdotally at the bedside better. Yeah. So we should get that answer. And the mortality in that, the primary endpoint in that study is mortality.
Yeah. And that's really, ultimately what we care about. I would say, it's great to get out of the hospital a few days early, but the big thing is to get out of the hospital.
Yeah.
All right. So the message here is, unlike hydroxychloroquine, anti-IL-6 antibody is not over yet, right?
Yeah, there's still more to go. There's other stuff where, I think the story should be over, but it won't die. All right, so I think that's it for me. Do we have some emails that we want to hit before
a couple here. The first one is just a nice story of Stephen, who was turned on to TWiV by his brother virologist. Over the weekend, his wife's aunt got sick. She went to the hospital with a 105 fever, difficulty breathing. appears to have phase 2 COVID. So she was rushed to the same hospital where Daniel Griffin works. And it turns out that looks like he's going to take care of her. And Stephen is very grateful because having heard Daniel on TWiV, Stephen is confident that the aunt will be getting the best care.
Yeah, actually, this is an interesting case, and I mentioned this reminds me to get back to what I was going to talk about. So this was a woman who, people did not know that she had COVID, but she came with this very interesting story of bilateral pulmonary changes. So initially the impression was, this looks like a bilateral pneumonia. It sounds familiar maybe to our listeners. But then they also noticed she was in heart failure. Normally when the heart fills and it ejects, it'll eject about 60, 70%. But her ejection fraction was cut in half. It was down like 35%. So here's this woman previously without any cardiac issues. Now she's in heart failure. She's got this bilateral pneumonia. What's going on? She's got elevated inflammatory markers. She's got the elevated neutrophil, the low lymphocytes, but the COVID PCR is negative. So we went ahead and we did COVID IgG. And a positive in this lab would be greater than 1. And so her IgG was up at 100. And we then actually had her daughters get tested. They also had high serology, so they also were positive. So it looks like somehow at some point, it looks like there may have been an exposure, but no symptoms, right? And so my impression is that this woman was suffering this multi-inflammatory phase. We actually gave her steroids, and today she was sitting up in a chair chatting. She had a number of interesting features. When I first saw her, I looked at her hair, right? This has become a telltale thing. And I was like, so what happened to your hair? And the nurse is like, yeah, her hair's all over the pillow. Yeah. I'm like, yeah, your hair's falling out. She's like, oh, it's okay. It's really thick. I'll be fine. And then she said, oh, did you speak to my brother? And I said, well, what's your brother's name? And she said, oh, I can't remember it actually. So I was like, well, you can't remember your brother's name. This is a teaching assistant. And she had the encephalopathy, she had the hair loss, she had the cardiac manifestations. And it was really amazing. We gave her steroids, dexamethasone, we gave her IVIG, and the response was, as mentioned, pretty dramatic.
All right. Landy writes, I heard Dr. Griffin make reference to aerosol generation by nebulizers. I'm aware that CDC considers it an aerosol generating procedure. The UK National Health Service, however, states that nebulized medication administration is not an aerosolizing procedure because the aerosol generated is not from the patient, but from the machine. They don't provide a reference, though. I'm curious what you think about their argument, especially as we have more pediatric patients with the disease. It may be hard to get cooperation with an MDI/spacer.
Yeah, this is a good point that's being made here. So yeah, different recommendations in different areas. So let's talk a little bit about why we say what we say and why everyone isn't saying the same thing, right? I mean, we should all be saying the same thing. When you are using a nebulizer, you're actually creating particles that are in that critical 1 to 5 micron level so that they can get deep into the lungs. Supposedly that can deliver the medicine properly. In all honesty, I have to say we really don't want them that small. You want them a little larger so they deposit in the upper airways and give you your bronchial dilation. So they're too small. They should fix their product design. And as I think the UK idea is, these are being inhaled into the lungs. So what's the problem? We're not blowing them back out. But the force of these jet nebulizers actually will create a little bit of a spray. And then as the person breathes in, it often triggers coughing. So they've breathed in these small particles into their virally infected lungs, upper airways, and then cough them back out. So this is great, right? That's a mechanical article, but where's the science? Where's the evidence that this is an issue? So there were a couple studies, actually go back 17 years. There was another outbreak, SARS-1. And in actually a study in the Toronto nurses, they looked at different activities that the nurses were involved in. And those that were involved in the nebulizing of patients were 3.24 times more likely to get SARS. So that was one of the sort of words of caution. So we're erring on the side of caution. There was another study where they did not show an increased risk in nurses that or healthcare workers that were involved in nebulizers. So we're not sure, but we, at least in the U.S., this is sort of a second tier per the CDC, where the CDC says these top numbers, these are clearly aerosol producing, there's less evidence to support nebulizer, but there is concern. So we've, as much as possible, switched over to MDIs, the metered dose inhalers. Chuck, did you want to weigh in on that?
Just the biology of SARS-1 and SARS-2 is a little bit different. So SARS-1 may be more infectious with more active disease. So an open issue, but I actually agree, with erring on the side of caution, which you said, Daniel.
Yeah, I think it's also timing. If you think about it, they come to an urgent care and they're in that peak viral level. That may be the time when they are potentially going to have the most spread if you give them a nebulizer. By the time they're in an ICU or they're in a hospital during the cytokine storm, the viral level may be low enough. We're trying as much as we can in our hospitals here to create negative pressure rooms so that we can nebulize if we need to, because this may be a way to keep them from ending up on a ventilator, which, as we know, is not great.
All right, last one for you, Daniel, from Sanjita, who is a pediatrician in private practice in Texas, and writes that if there's one podcast every scientist and physician should listen to, then it's TWiV. All right, question. Dr. Griffin mentioned they've started testing for COVID in the patient exam room. So far, we have been testing everyone in our parking lot. But as you can expect, parking lot is less than perfect for a clinical exam. Pulse oximetry doesn't work outdoors. Neither does the touchless infrared thermometer. If we were to bring these kids to the exam room and do the test wearing PPE, do we need a negative pressure room? We don't have one. Would a good HEPA filter help, or should we just clean the room thoroughly after the patient leaves?
Okay. Now, this is great, Sanjita, and actually, thank you. This lets me hit on this topic again. And I mentioned this early on. This was the number one question when I was giving this talk to the urgent care providers in the tri-state area. That always makes me think of Phineas and Ferb when I say the tri-state area. But there were hundreds of physicians on, and this was their top question, is we are trying to increase access to COVID-19 testing. How do we do it safely? Because outdoors has a lot of limitations, as mentioned. And the big thing is just to embrace the science, right? This is not March anymore. We now have millions of infections. We have months of information, very well studied. The main way that this is spread is through droplet. So the risk for you is you go into the room with the patient, you're within 6 feet, they are talking, singing, sneezing, coughing into your face. We have ways to protect ourselves, wearing a mask, wearing eye protection, wearing all the personal protective equipment that we're used to now doing. You don't have to be in a negative pressure room unless there's an aerosol producing procedure. And as we talked, if anything, we're erring on the side of caution when we talk about nebulizers. But if the person vomits, if the person needs to be intubated or suction, there's very few aerosol producing procedures that are going to occur in this setting. So you bring the person in, they wear a mask, they push it down a little so the nose is accessible, and you do your testing. The mask comes up, and then we're good to go. So you can really, if you limit your exposure, not only can be safely done, but I think that this is a great thing for people to start introducing into their practice. The person leaves the room and we wipe off the surfaces. We still think that that's a minor way of transmission. I think there was, you looked at some of these studies and people claim you had to have 100 people cough onto the table before it really got to that infectious level. So the big thing is protect yourself, get them in and out. We have approved products with certain dwell times where you can clean that surface. If the person, let's say they do vomit, this is going to happen. Then what we do is we close the door. We give it 30 minutes. A normal room without negative pressure will take about 30 minutes for things to settle down. Then you do your 10-minute dwell time and cleaning, and you can move on. But no, I think this can very safely be done in patient exam rooms without creating exposures for the staff or the providers.
And finally, any recommendations on stopping estrogen-containing birth control in teens with risk factors for COVID? Estrogen creates a hypercoagulable state, but so does pregnancy.
Yeah, this has actually come up a few times. I guess I'll fix my bow tie to sort of bring back bad memories. But this is where I was on CNN and I was supposed to be talking about Trump and testing. They said, Dan, let's talk about pregnancy and COVID. This is like early March. I'm like, nobody knows anything about that. Thanks for asking. But this is one of those theoretical risks. We haven't actually seen significant issues with hypercoagulation in young women on estrogen-containing birth control. And we fortunately have not seen significant issues in pregnancy. There was one paper that came up sort of suggesting a little bit of a signal of more hospitalization, but then I think we may be just more likely to hospitalize pregnant women because they're pregnant. So fortunately, this is not panned out as a significant concern. And there are lots, right? There are lots and lots of young women on estrogen-containing birth control. We're not seeing a signal there. And there are lots of women who still get pregnant. I think maybe more during the pandemic because we're sheltering at home. And we seem to be doing okay so far. So I think we're going to be okay with this. So I would not recommend stopping estrogen-containing birth control or doing anything special as far as pregnancy.
All right. That'll do it for this week's COVID-19 report with Dr. Daniel Griffin. Thanks, Daniel.
Oh, thank you so much, everyone. Take care.
And Chuck Knirsch, thank you for joining us.
Good seeing you both.
Joining me today from Fort Lee, New Jersey, Dixon Despommier.
Hello there, Vincent.
I'm going around the Hollywood squares, that's how I know who to introduce.
Yeah, that's right. It's overcast. The temperature is actually tolerable. The humidity feels as though it's less than it has been over the last week and a half or 2 weeks. And next week promises to bring a lot of rain and cooler temperatures. So maybe the trout fishing will pick up. Who knows? But it's been horrible in July.
I have no sympathy for you.
I know.
24 and cloudy here. And you're not too far from me, so it should be similar. Also joining us from Madison, New Jersey, Brianne Barker.
Hi, it's great to be here. It is similar here, 79 and gray. So about 27 Celsius.
From Austin, Texas, Rich Condit.
Hi, everybody. It's 95 degrees in Austin, Texas. That's going to be the high for today, according to this. And we may get some rain this afternoon. It's partly cloudy. And I feel compelled to do this. The caseload in Austin, it continues to decline.
Yay.
And so that, however, that is the 7-day moving average for hospitalization continues to decline. I do notice, and the hospital occupancy is declining as well. However, I do notice that if you look at the individual cases per day for the past week, they've been about constant at between 220 and 250, which is 2.5 times what it was at what was for us baseline. So it'll be interesting to see where that levels off in terms of hospitalizations. Certainly, it's not going to go down to zero, given the current behaviors we have in place.
You got Texas behaviors.
Texas behaviors, 50% restaurant capacity, bars are closed, masks are mandated, social distancing, appropriate hygiene, and locally the parks are closed. For another
but are they obeying those?
Physical.
By and large, I think people, they must be paying some kind of attention because, the caseload's decreasing.
Okay.
And from Western Massachusetts, Alan Dove.
Good to be here. It's 84 Fahrenheit, 29 C, and sunny. Actually, it's
84. Wow, what a difference. Well, it's different in the shade and the sun.
How can you have
break
sun?
The clouds.
How can you have sun there? How is it possible?
I don't know. We also have coming up starting tomorrow, I think, August 1st. We will have a mandatory quarantine for travelers that is going to be enforced with a $500 a day fine if you don't follow it. If you come from out of the states that meet Massachusetts criteria for low COVID-19 incidents, then you have to quarantine for 2 weeks on arrival in Massachusetts.
Wow.
And there's a form you have to fill out. Now, obviously, if somebody drives in, they're probably they're not going to have border checks.
Exactly.
But, they're going to catch travelers at the airport, and you're not going to be allowed out of the airport or the train station until you fill out your form, and they've got to be able to contact you and all that. Now, Rich and Brianne and Dixon would actually be allowed to visit Massachusetts without quarantining, because New York and New Jersey are okay by our stats. I'm sorry, Rich. Texas does not meet the Massachusetts. In fact, it's only New England, New York, and New Jersey that currently meet the requirements.
Really?
Yeah.
What is New England, a new state?
New England is a new state. Yes, we're gonna just break off, and so the requirements are you have to have case counts below 6 per 100,000 population in your state, and you have to have positive SARS-CoV-2 test rates below 5%. So you can't just under-test your way out of the problem.
So, Alan, in your little hamlet, have you had cases?
We have. I don't have a case count. I think they've stopped doing it by town, or they're doing it by county, but not. And
overall, what is the situation in Massachusetts?
It's pretty good. It's the reason they implemented this quarantine actually is that it's better than most of the rest of the country, and New England generally. Massachusetts was early in the first wave because we had that super spreader event at the Biogen meeting. And that catapulted us to the top of the numbers very early on. And then we had the, just up the road from me, the Holyoke Soldiers Home, which was just a catastrophe. They lost a whole lot of people. It's a huge nursing home facility for veterans. And it made the national news. It's, so that obviously upped our numbers as well. But now that that's all resolved and under control, and they've had the stringent measures and everything, it's come way down, and we're holding steady. We're not coming down any further. It's that little last bit that I think probably doesn't go away anywhere until you get to a vaccine, or unless I think maybe if you're New Zealand and you can just
or if you live in Maine, completely. Maine has a very, very, very low rate.
Maine does have but it's not zero.
No, it's not zero.
They do have some infections.
A few.
Vermont and New Hampshire also had the advantage of being small populations.
Remember, if you have 1 or 2, you have 10 or 100.
You have 1, you
easily.
Have exactly.
It's more than you test for. Right.
So, and it is there was a model that was just released. New York Times had a story about a model that predicts how many students would likely show up with SARS-CoV-2 infection on the first day of school if school starts. And you can do it. They've got one of these quantitative journalism things where it's data-driven graph, and you can click on your county and adjust the numbers. And so if the 1,000 students that attend my daughter's high school all show up to school, we can expect about 2 of them to show up the first week of school with the virus.
After that, more.
One would assume. They still haven't decided what they're going to do, but they're saying the administration is favoring a hybrid approach, 50-50. I guess we'll see.
Well, we have
Are they going to take temperatures?
No, they're not. I went on the online meeting that the school superintendent had, and I went in the chat and I said, "What's your plan for testing for virus?" And nope, they're not planning to do any virus testing or checks or anything.
And what's the reason? What's the reason for that? Do we know?
They're just not set up for it.
It's no excuse.
Well,
get set up.
Get set up for it.
No, and I said, if you're not testing, then this is going to be a disaster. And
that's right. That's exactly right. That's exactly
so. So we've had a number of requests for at least one episode, which we should call "Back to School with COVID-19." And so,
yes,
I think I will do that. I'm going to get a few educators in to describe, what it is that they need. My friend told me the other day, if you haven't been to school lately, you have no idea how messed up it can be in terms of facilities.
or what they're afraid of, by the way, because one of the women in this building that I live in taught for 27 years at a school in New York City, a private school. And they told her that she's going to have to go online, and then she has to come in, then she has to do this, and she quit. She says, "I'm retired right now."
Yeah,
right now. It's probably similar in other districts, but in our district, they had already told the teachers to make 3 separate plans.
Exactly.
One for school is open,
it's
one
stupid.
for hybrid school, which nobody understands how that's going to work out, and the other for online school, which is what we did in the spring. But if they do the pure online option, they want to make it a little more rigorous. Because in the spring, obviously it was all new, and they were very, tolerant of a whole range of things, and they went to all pass-fail grades, and just like if you showed up and did anything, you were going to pass.
Right.
So they want to make it a little more rigorous than that for the online part. The hybrid part, I don't even know what the approach is there. They're going to have half the kids on Monday and Tuesday, half the kids on Thursday and Friday.
No, that's crazy.
And Wednesday is going to be this hygiene theater of let's disinfect the school. Which even though we know fomites are not the main transmission route, we're now disinfecting all surfaces. Okay, fine. But the half that's not at school is supposed to be online. So then the teacher is presumably going to be talking to the classroom with a mask on video. And that's going to be the lesson that the students at home are supposed to interpret when they can't even see half the expression and they're getting the audio lag and just.
So we are also thinking about a similar hybrid or online. And I was part of a group of faculty that actually did some piloting of that hybrid teaching. And what I will say is that anyone who is thinking about doing the hybrid teaching, I would strongly recommend doing a pilot. So we had a group of faculty, half on Zoom, half in a classroom. Someone played the instructor, and we had a bunch of our tech department there trying to figure out how to make a lot of those details work, and what it would look like, and which different scenarios the students could hear the professor, and all of those things. And it was 2 lengthy meetings of us playing with things before we kind of figured out how it would work. And everyone went home and changed their syllabus for what types of activities would actually work. I would especially recommend that you play with your camera to see if you can see the chalkboard. If you write on the chalkboard. That became that became a rather large sticking point in one of our trials, was how we could get the camera so that the online students could see what was written on the chalkboard.
Right.
Yeah.
Things that don't occur to you unless you've actually done it.
Yeah.
Okay.
Yep.
So what do you do about shop, gym, sewing, or engine repairs?
I don't think there's shop class anymore.
Forget about it.
But gym, I think is just
there goes the requirement
off the table.
Yeah.
And
we do about special ed.
They still haven't. No, there were questions with the local superintendent's session, like what are you doing about music classes?
Yeah.
That's right. And they're still trying to figure that out.
Art.
And special ed, they are making special arrangements because obviously that's got its own issues, and you can't necessarily do half and half, and online school may not. Just so that's its whole thing.
Yes,
of its
own.
At least we'll be ready for the next pandemic.
Well, except
you think?
No. We'll be super ready. What'll happen is we'll be super ready for this pandemic when the next one comes along.
That's right.
Yeah.
Right now, we're going into this pandemic, we were really well prepared to respond to the outbreak of HIV.
Right.
True.
Right. If we had another HIV, another sexually transmitted retrovirus had broken out, we'd have been on that.
Yeah.
Boom.
It's kind of like how the military is very well configured to defeat the Soviet Union. Right.
Yes.
The previous war, we got that down. So I think after this, for at least a few years, we'll be very well prepared to deal with another coronavirus respiratory disease breaking out until we, forget to maintain all those preparations.
I think the big hope is that they can be vaccinated over the Christmas vacation. Everybody comes back immune, right? Ha ha ha.
Forget about it.
Yeah.
Forget about it. Not happening in your dreams. You know?
Well, that I would like that for Christmas.
You
That'd
know,
be great.
Yeah.
Which I just want to mention that we had a letter on Wednesday, which was fabulous from someone who understood vaccine development. Remember, Rich? You got to go back and listen to that or read it, because he said, like, okay, normally you do your clinical trials and then that informs how your final manufacturing conditions, and then you scale up. But right now we're manufacturing along the clinical trial. It may be that what you make is not the same as what you find you need, and that's a big problem. Remember that,
Somebody's
Rich?
paying for it anyway, aren't they?
Yes.
Well, that's what Fauci told us. He said we're making a risk. We're going to lose money, if anything. But
Sure.
Yeah, but you won't lose lives, though.
oh, I understand we have to do this.
Maybe.
I'm just pointing out what the issue could be.
Yeah.
All right, let's move to some science. Before we have two interesting papers to talk about today.
We were actually, this was a surprisingly on-topic discussion for the beginning of a TWiV episode. Although I have to say, I liked This Week in Gardening. It was a nice.
What did we do
for the show?
Last time we were gardening?
Yeah.
We had you were telling us all about
your
harvest of
lettuce
your vegetables.
Yeah.
Yeah, I mean, it was only a few minutes.
And it occurred to me, TWiG.
TWiG. Yeah.
Speaking of gardening, yeah. We have two cool papers I want to tell you about. But first, there is a postdoctoral position available at the Rocky Mountain Laboratories in Hamilton, Montana, to work on SARS-CoV-2.
Count me in.
You go. You should go, Dixon.
Fishing is absolutely stunning. I'll go. I'll start my career again.
Dixon and I spent a few days out there a few years ago.
That's a beautiful place.
We did a TWiV, right? Remember with Diane Griffin?
Forget.
And Dixon took me fishing, and I took a video of Dixon, which I still have on my. I haven't done anything with it, but he caught this huge fish. Actually, he caught hundreds of fish. It was like boom, 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 boom.
Are you sure you didn't just catch the same fish hundreds of times?
No, we were moving down the river.
Smarter than that.
Really?
No, we were moving down the river.
I've definitely caught the same fish more than once.
Well, then we won't go. We're not going there. Come on.
So I will put a link to the announcement. But Vincent Munster, we've reviewed his work often here on TWiV, and there's an opportunity to work there. So I'll put the Google Doc in the show notes so you can see, and there's an email and other information about this scenic Bitterroot Valley. It's really pretty there.
It's very pretty. In fact, there was a moose that came through the backyard of this facility that we're staying at.
Yeah, that's right. I remember that. And,
just missed it.
So at night, Dixon and I, we would sit outside the hotel. What is it? The Bitterroot Inn, right?
Yeah, that's right.
And we had some bourbon or something.
Some amber fluid.
And there was a lake. There was a lake next to the. And Dixon would explain. He would explain the ecology of this lake and why it was bubbling and eutrophic and all this stuff. And then, of course, the mosquitoes got too fierce, and we had to go.
That's right.
That was very cool. All right. So today, first, continuing on a theme, or I should say, an arc. About kids and the potential of them transmitting. Last time we talked about a study out of Korea which showed that while very young children, less than 9, transmit at a lower rate, from 10 to 19, it's what they consider school-age kids will transmit just as well as adults. All right, so and then today we have a paper that just came out this week in JAMA Pediatrics. That's not jammies. It's not pediatric jammies. Journal of the American Medical Association Pediatrics. A research letter, age-related differences in nasopharyngeal SARS-CoV-2 levels in patients with mild to moderate coronavirus disease. All right, and I love this sentence. Everyone needs to listen to this. Children drive spread of respiratory and gastrointestinal illnesses in the population. But data on children as sources of SARS-CoV-2 spread are sparse, and that's true. But it's true. We don't often mention this. Kids are major drivers of respiratory and GI infections.
Even before they're licensed to drive.
Even before they're licensed.
This is all true.
And so this study is trying to address that. And what was done between March and April, they had patients in various places at a medical center in Chicago, a tertiary pediatric medical center.
Right. So this is, should we do authors?
What's that? What's an author?
An author.
Go ahead.
It was a movie about a butler. No.
No.
So Taylor Held Sargent is first author. Larry Kochelek is senior author. These folks are at Lurie Children's Hospital in Chicago and Northwestern University.
Got it. Okay. All right. So they collected specimens, nasopharyngeal swabs, and did RT-PCR, as you will see. But they have a cohort of 145 patients. These are all tested positive for SARS-CoV-2, and they range from age younger than a month to 65 years of age. All right. And then they did their own quantification of RNA by cycle threshold, right? As we have talked about before, the PCR reaction goes in cycles, and the more cycles you need to detect nucleic acid, right, the higher the cycle threshold, the less nucleic acid is present.
So that the higher the CT value, the lower the concentration of virus.
Yeah.
Or the concentration of viral RNA.
Viral RNA, yeah,
Yes.
because in the case of SARS-CoV-2 infection, remember, you take a nasopharyngeal swab, you're getting cells as well as virus particles, and the cells have mRNAs in them, which are going to be amplified as well. And the mRNAs are not the whole genome, right? So that's a caveat here. That's not all full-length viral RNA, obviously. And so these are patients with mild to moderate illness. They were caught for this study within a week of symptom onset.
Yeah, they actually talk a little bit about criteria they used to exclude some additional patients, including having very serious disease, being further from symptom onset. And so this is just a sort of group of patients that really meets the strict criteria.
All right. And there is one figure in this paper. And, you know, a few of you have written
Should we put this on the...
Well, I've got yelled at for doing that, you know?
Oh, did you?
Yeah, I did. I'm going to do it, but don't yell because we'll describe it as best we can.
What was the objection?
Because they're listening in their car and they can't see it.
Okay, but we will talk through this. Don't
That's
worry.
what they want.
But
They
for
said-
the people who are watching on video, this is a nice...
Yeah, I promised that we would talk through it.
Yes.
Yes.
But the one figure in the paper is a whisker plot of a bar graph, basically. 3 groups of individuals, less than 5 years of age, 5 to 17 years of age, which is my age group, and then greater than or equal to 18. All right. And then on the y-axis, they have the RNA levels. This is cycle thresholds, right?
Mm-hmm.
And you can see that, you know, there's a big range in the numbers here, but all 3 groups overlap. And the less than 5 seems to have a lower cycle threshold, which would mean they would have more viral RNA than the 5 to 17, which is similar to the greater than or equal to 18.
And for people who aren't accustomed to this, the whiskers on the plot, those thin lines extending up with the ends on them, those are the error bars. So you'd expect the results to be within that range. And so the fact that those are almost as big as the graph is telling you that there's a wide range here. And yeah, the under 5 seem lower. The 5 to 17 seem the same as the adults.
Yeah. So
and the other thing to note about a plot like this is you've got a box, which gives you the 25th to 75th percentile.
Right.
But in the middle of the box, there's a line, a dark line,
Mhm.
and that is the median. And so really what you want to be looking at here is where that median is, and comparing the median, that dark line in the middle of the box, among the 3 groups.
Yeah.
Those medians are the numbers that they actually comment on in the paper.
Right. The median is where things work out, and we'd say, okay, this is the number if you need one number. But the rest of the bars are there to let you know that if you looked at a larger population, you could be anywhere in there, and that line could move.
Vincent, how do we know how many people are in each group here?
They give the numbers.
It's broken
Younger
down.
children, less than 5, 46.
46.
5 to 17, 51.
All right.
18 to 65, 48.
So it's a
Right.
pretty even number in each group. Yeah. I mean, you would love to have thousands, right?
Oh, sure. Yeah.
You sure would.
Then you'd get those error bars smaller, hopefully. Well, maybe.
Yeah, and if you were
Actually, not
submitting this
necessarily.
for a thesis, I think that your mentor would say, go back and do it again.
Well,
What would you
there's
like them to do?
there's
but
almost
it's
no difference. I mean, you want to say there's a difference, but
right. If you were trying to look at a molecular mechanism, you wouldn't want error bars like this. But in
You wouldn't.
epidemiology, this is
no, I appreciate
you're working
that.
with found data.
I mean,
appreciate
at worst, they're all similar in terms of RNA levels, right? Which
Sure.
means
Yeah.
young
you could
kids
say
are-
there's a trend. I like the word
Yes.
trend.
So
better.
while this doesn't prove transmission, it's showing that they're shedding viral RNA, and
Oh yeah, that's right.
Sure.
we can make and others have made correlations between cycle thresholds and how much RNA you would need to get an infectious dose. Like, Daniel Griffin has said over 1 million copies of RNA. That's when you're transmitting, but not below it. So what they say here is that the differences between young children and adults approximate a 10 to 100-fold greater amount of virus in the upper tract of young children. And I would say, I don't know. I would really like to see infectious virus titration, but we're not going to get that.
They fess up. They fess up at the end of this. They say that that a limitation of the study is that they're not actually measuring infectious virus. They know that.
But there's viral RNA here for sure.
Yep.
And to say that
Yes.
kids are not transmitting is not consistent with this level of viral RNA in the upper tract, right?
I mean,
Well, I'm not convinced by the numbers on the paper that we did Wednesday, whenever it was, that says that the younger kids are not transmitting as much. That was a very small sample size and very few kids. I would like to see a lot larger study, in particular in light of this, where these kids are cooking up a lot of virus.
Well, remember
And it's
the problem with the study out of Korea, it was done when school was out, so you don't have
That's true too.
Yeah.
And in practical terms, a study like this, where you're looking at 5 to 17, I think is more relevant, at least for the U.S., than a study where you're looking at ages, in other groups, because that is realistically what districts are going to do. They're going to open the elementary schools, the middle schools, and the high schools, and treat them as all the same. And if it turns out that a 6-year-old is less likely to transmit the virus than a 16-year-old, that's probably not going to play much into the decision. So
I think that it would be actually really hard to get to the point of likelihood of transmission between that 6-year-old and the 16-year-old once you start adding things like differences in behavior
yes,
of those populations.
sure.
yes,
The other thing is that all these kids were symptomatic.
Mhm.
They were either
Right.
mildly or
Yep.
moderately
Yes.
symptomatic. So what about the kids that are not symptomatic at all?
Right.
That's what you really want to know about, right?
Well, yeah, of course. They're and those are harder, obviously harder to identify because these people
Yes.
went to the hospital because they didn't feel well, right?
Right.
And so the others would require a screening study.
So would a kid with these symptoms, would they be kept at home, do you think?
Well, I think if they're tested,
I
and
would
they're
sure
positive,
hope
yeah,
so.
they have to be.
No, I mean,
tested at
without
home.
the test or anything. It's just you don't feel well. It's not a
yeah.
Ferris Bueller situation. Yes, stay home, please.
right. No, in the current situation, there is advice that if you're febrile, if you have a temperature over 100,
Yeah, home.
you don't go to
That's
school, you don't go
That's
to work. Just we don't want to see you.
Exactly.
My wife got sent home from work just recently because she showed up. The temperature outside was like 98 degrees, and she walked in. They took her temperature, and it was 100.1. They said, "Sorry."
Really? Really?
So-
Did she laugh all the way home?
no, she had just had like an allergic reaction to something earlier in the day, and had gotten like a little flushed, I think, and so
So what? How long did they tell her to stay home?
just till her temperature came down, which of course it was a couple hours later, but
Yeah.
then she just went in the next day. She was
Oh,
fine.
funny.
So they're now, granted, she works at a hospital, so they are hypersensitive about this. But the understanding I have is that with school reopening, they would just tell parents, if your kid has any kind of a fever, keep them home.
Yeah. I also want to mention, I think this is a paper we did before, although now I can no longer remember more than a week what papers we've done. Used to be able to do that, but This is an emergent infectious disease article from June. Culture-competent SARS-CoV-2 in nasopharynx of symptomatic neonates, children, and adolescents. It's a group out of Switzerland. They could isolate infectious virus from 12, which is 52% out of 23 infected children. So these are PCR-positive children. About half of them, they got infectious virus. The youngest 7 days old. And they say the levels are comparable to adults. So they're shedding, again, small numbers, but they're shedding infectious virus. And
Sure.
I think the main take-home is I don't think we should make decisions about school based on the assumption that children do not transmit, because they likely do.
Exact.
Yeah.
And
Yeah,
I think we have ample evidence that children do transmit this virus. And the notion that they don't is a combination of some fragmentary data and some very wishful thinking.
Right.
Very wishful thinking.
I would agree.
Well, I think it's also political thinking, right? That's driving this as well.
There's that too.
There is that. All right. So then
We'll be doing the experiment in September.
Thank you for mentioning that. We are going to do it. Yeah. And hopefully, as Daniel often says, we'll be ready to do some testing on school-age children, and we'll see.
Good luck with that.
Yeah.
You need a spit test.
I mean, I personally think we're going to have big outbreaks as soon as school.
I
is
agree
over.
with you.
I don't think we're going to have them as soon as school opens. I think it's going to be a few weeks.
3 or 4 weeks. Yeah.
A lot of schools start to open in August already. Like the medical students would start coming back here in the first or second week of August, right?
You got it.
Yeah.
You got it.
Okay. Now we have a basic science paper, but stick around because it has important implications.
This is important basic science in the current context.
Here, here.
It's a Nature Microbiology paper. It is called Evolutionary Origins of the SARS-CoV-2 Sarbecovirus Lineage Responsible for the COVID-19 Pandemic. The authors are Boney, Lemmy, Yang, Lamb, Perry, Casto, Rambeau, and Robertson. Out of Penn State University, Rega Institute in Belgium, Liverpool. Oh, that's the Shanjiaotong Liverpool University, but it's in Suzhou, China. University of Hong Kong, University of Texas Arlington, which I believe we've been to, University of Edinburgh, University of Glasgow Center for Virus Research.
I just love this. There's 1, 2, 3, 4, 5. I don't know, about 8 authors or something, and 7 different institutions.
That's
Global
cool stuff.
Right? Yeah. It's amazing.
Now this is a purely. Yes, sir. Go ahead.
Could you please just clarify the word sarbecovirus?
Yeah, sarbecovirus is a genus, a subgenus actually in the Coronaviridae family, and this includes the SARS-1 and SARS-CoV-2 viruses.
That's what I thought, but I thought our listeners might want to.
Thank you very much. I had meant to, but as usual, my intentions fall by the wayside like drops of water. Once I was speaking to an Italian scientist who directed a facility of Merck in Italy, and I said to him, "Don't you have problems with the Merck over in the U.S. trying to micromanage you?" And he said, "No, their words fall like drops of water into the ocean." So poetic, right? I'll never forget that. Okay. Now, this is the key sentence here. Identification of the infection source for zoonotic pathogens like SARS-CoV-2 is crucial because this may allow health authorities to separate human populations from wildlife or domestic animal reservoirs posing the zoonotic risks. Right? So this you need to know to stop future outbreaks if you know where the potential sources of zoonotic pathogens lie, right? Now, what's interesting here, all the sequences, this is a purely computational biology paper. All of the sequences are vast majority of them we had already before SARS-CoV-2. And all we had to do is look at them and do this analysis. And we would have seen this startling conclusion, which is the lineage of bad SARS-like viruses that gave rise to SARS-CoV-2 has been circulating unnoticed in bats for decades.
Really? And
we know that these can bind ACE2 and have the potential to infect human cells. They've always been there. And actually, after SARS-1, we knew they were there, but we didn't do anything about them. So The key to this paper, to understanding it, is that coronaviruses are highly recombinogenic. What does that mean? When two different coronaviruses infect the cell, their genomes can recombine. So out come progeny with pieces of genomes of either parent.
Viral sex.
Viral sex, incredibly recombinogenic. And this makes phylogenetic analysis hard, because if viruses are shuffling bits, you don't know where these viruses came from originally. They have a wonderful way of saying this later. Let me see. Let me fast forward to it and find it here. The difficulty is that different parts of the genome may have different histories, right, in terms of where they came from. Like you have two parents, easy, right? You don't have like 5 or 6 or 7 or 8, and that's what these viruses might have, or even more. So you have to, and this paper, what it does is to remove all of these regions that have arisen by recombination by computational methods, which they say are too complicated to describe here. But they do it. They use 3 different approaches, bioinformatic approaches.
Now, to be clear, they do have the code. All the code is available on GitHub. The data are available also on GitHub. So if you want to delve into this and you understand what you're doing, you can actually download everything they used and analyze it. But in the paper, they're not going to go into it.
Right. I think that one other thing that's important to point out is that the coronavirus genome is basically one piece of RNA.
Yes.
So they talk a little bit about influenza, and people might be familiar with influenza. That has a few different pieces of RNA that mix and match, called reassortment. Here, we're actually taking this one really long piece of RNA and getting parts from different parents.
Mm-hmm.
Right.
And so what we need to be able to do is figure out which parts came from that recombination and which parts are sort of blocks that tend to travel together.
Yeah, they say that nicely. They say influenza viruses reassort, as you just said, but they do not recombine. That means origin questions for influenza outbreaks can always be reduced to questions for each of the 8 segments. That's all you have to track, and that makes it a lot easier. You don't have to worry about them recombining.
Right.
So it's as if influenza's already done all of the computational biology.
Yes. Influenza has neatly compartmentalized itself into 8 pieces, and these are the 8 pieces that are going to be exchanged.
Indeed. If viruses could do anything, they would do their own computational biology.
So are all regions of the RNA of COVID-2, are they all
COVID-2 is a disease, Dixon. COVID-2 is a disease. COVID-2 doesn't even exist.
Okay. Do they all recombine equally well?
No.
Someone said
Does
to
not
me,
look like it, no.
Someone said to me, I'm too harsh on you, Dixon.
No, you're not harsh.
I always pick on you. I always correct you.
That falls into the water like drops of rain.
Telling Vincent to be nice to Dixon is one of our major arts.
Nah, it's okay.
Dixon, you were actually listening.
So Dixon, if I think this addresses your question, others can chip in. If not, there's the top panel, and the first figure shows recombination hotspots. Okay, so they can computationally, from comparing a bunch of genomes, figure out where recombination hotspots are. So it's not equivalent along a genome.
Mm-hmm.
And conversely, in between the hotspots are places that are more likely to not be subject to recombination and conserved.
Uh-huh.
It's very cool. Yeah,
and in fact, the spike protein is one of the regions that doesn't have a lot of recombination junctions in it.
Yeah,
if I read this correctly.
And if I'm not mistaken, this is not that unusual just for nucleic acids in general, that you see hotspots of recombination in other areas. I mean, the human genome or whatever other genome you want to look at, some areas recombine better than others.
Absolutely.
Yeah, for those viruses that do undergo recombination, that's correct.
So good question, Dixon.
Yes.
Right on the money.
Poorly phrased, but good question.
Right on the money.
So just to clarify, Dixon, the virus is SARS-CoV-2. And you had said COVID-19. I think you were making a recombinant of the two terms.
What I wanted
He
to say
jumbled
was,
two things together. COVID-19.
All I wanted to do is just say the virus.
I know, I got it.
virus.
Okay.
Yes.
So in this paper, 3 bioinformatic approaches to remove the recombination segments, right? To identify putative non-recombination or non-recombinant regions. Then they do phylogenetic analyses with those. And they take something like 68 sarbecovirus sequences that they have, and they subject those non-recombination parts to phylogenetic analysis.
So that's the bioinformatic equivalent of doing 3 different experimental approaches to see if you get the same answer, which
Yes.
I have always thought the most powerful papers that I've read are where they take quite different experimental approaches to see if they get the same answer.
And that's called rigor.
I always love that.
That's called rigor, scientific rigor.
Rigor.
There you
And
go.
nowadays,
Yes, like we showed this in one way, and now we're going to do a biochemical experiment, show it in another, and now we're going to, So that's what they're doing.
it's good. It's always good to do that.
It's very good.
A lot of people are resistant because they don't want to take time to redo it, but they have.
It's
they
3
should.
times the work. Yeah.
It's good to do this. So the conclusion is bats are the primary reservoir for the lineage that led to SARS-CoV-2, and they believe the virus was in bats basically, and all the properties it has came out of bats and not pangolins. But the end virus infects both humans and pangolins, but it didn't evolve in.
And this ability, the sequences that allow it to bind the ACE2 receptor in humans are just there circulating in the bat viruses. This is something that happens in the bat viruses. It doesn't require an intermediate host to acquire that ability.
Yes. To be clear, though, that 20% of all mammals are bats, so it's not in bats. It's in some bats.
Yeah, and that's right. This sequence arose randomly, and as you'll see, it's some branches of the tree it's lost, and in others it's maintained. And if you happen to have contact with a human and a bat harboring that virus, then that virus can infect humans. But apparently no selection was needed to bring up that high affinity ACE2 binding region. So they have 68 sequences of these viruses from bats, including SARS-CoV-2, SARS-1, RATG13, the famous isolate, which is the closest to SARS-CoV-2 in genome sequence, and many others that they have sampled as using the sampling of many groups, but EcoHealth Alliance work, as we talked about with Peter Daszak. And they run their analysis to remove these non-recombining regions. So now they end up with breakpoint-free regions. That is, areas of the genome they think have never been shuffled by recombination. How do you do that? Well, computationally, you look at all the other parts you look for the hotspots, and you rule those out. And you see if there's any evidence of recombination in this sequence. And if you don't have any, you make it a breakpoint-free region. But of course, you may have missed it because you didn't sample enough, and that's always theoretically possible. And as I say later, the more we sample, the better this analysis will get, right?
Yes.
So they end up...
and since this is a computational experiment, you could just run this every time somebody finds a new bat virus.
For sure.
And just keep it going.
Yeah. So again, they run these through the 3 ways of removing the recombination sequences. And they say they all point to a single ancestral lineage of SARS-CoV-2 and RATG13, which is the closest to SARS-CoV-2 that's been isolated from bats in Yunnan. And they also further look at subregions of the S protein because they're interested in the part of S, the receptor binding domain, that confers high affinity binding to ACE2. And they try and see if they can track the movement of or the evolution of that position, right, in the spike protein gene. And they have a particular region, it's called the variable loop region. It has 6 amino acids that give SARS-CoV-2 high affinity ACE2 binding. And that sequence is also in the pangolin, but it's not in RATG2. So they say the simplest explanation, which they call the most parsimonious, that means the simplest, is for these sequences. Like why do these bad viruses have it? It's that they were present in the ancestors of SARS-CoV-2 and RATG13 and this pangolin isolate from 2019. And they were lost through recombination, and that's why RATG13 does not have the high affinity ACE2 binding properties. It's always been a puzzle. Like it's so related, but it doesn't have. So the one question was, well, did SARS-CoV-2 pick it up subsequent to RATG13? But apparently not. It was present long before SARS-CoV-2 and RATG13 diverged. So they say this provides compelling support for the SARS-CoV-2 lineage being the consequence of a direct or nearly direct zoonotic jump from bats, because the key ACE2 binding residues were present in viruses circulating. So they were already there. They didn't have to be selected for in humans or any animal that has a human ACE2-like receptor. That's important.
It's especially important because you had mentioned that much of this could have been done before with sequences we had. And it makes you think, well, if we had done this before and realized, hey, look, many bat viruses just have a receptor that can bind to human cells, that would have been further evidence that we should have been doing some coronavirus research to prevent some pandemic like this.
Yes, it's really too bad.
And in fact, results like that for other viral lineages have been reported. I mean, raise your hand if you've seen a paper or been to a talk where somebody says these sequences imply that this lineage has pandemic potential, right? Yeah. You know, this is going on, and we are seeing this sort of thing occasionally. And we could have seen this, but whether we would have done anything about it, I think probably not.
Yeah. So, I think if you wanted to work backwards and say, if we had known about this a long time ago, the warning the region of the world that this is going to happen sometime in the future would have little effect on the wet markets of Wuhan, I think. People would say, well, we'll do something about it when it happens.
Well, Dixon, it's not clear that it's not at all clear that this one originated in a wet market. It could have originated in the countryside, right?
Sure, of course. But what would be the strategy if you had known in advance?
Oh, very simple. Make broadly inhibitory antiviral drugs that inhibit these bat SARS-like viruses. And you target the RNA polymerase, the most conserved protein among these viruses, and you check all these bat viruses. All you need is the polymerase, and then you do the human isolates, and you find compounds that can hit them all. And I'm sure that would not be hard to do. It would cost less than the trillions that are being spent now, right?
Did we ever do that?
No, nobody ever did.
That's what I thought.
and in fact, we got a warning shot with SARS.
Yeah, we did.
SARS-1, that this lineage of viruses was bad news and could do this, and we figured out where it came from, and that's why we were sampling these bats, because there was a feeling that this could happen again. Let's see what's out there, and the more data we collected, the more it became clear that this, we're sitting on a time bomb here. So the work Vincent just described probably should have been done. And this is not Monday morning quarterbacking. This is the kind of thing that you could have figured out at the time and funded. And I suspect maybe there were even some people proposing that who just, didn't have the backing.
I anticipate a couple of other things coming out of this, out of the pandemic, not just this paper. But I think that we will probably, I would hope that we will learn from this what the best practices are for containing, minimizing the effects, containing a virus without overly, unnecessarily damaging the economy and people's lives. And I also think, in the case of influenza, we make a new vaccine. We have the potential to make a new vaccine every year. Okay. And one of the reasons for that is the platform is very well understood, so that you can just slam a new hemagglutinin into the same platform. And the testing, the assumption is that all the safety stuff is going to be the same. And the testing just consists of making sure that the virus grows okay and that you get a reasonable antibody response in a relatively small sampling of individuals. Okay. And I kind of anticipate that the same thing, if the vaccine platforms that are being investigated now are successful, I could envision the same sort of thing happening, where you could have a vaccine actually online and cooked up with the technology in place in a really short period of time.
Yeah.
But I'm dreaming there. But
no, I see this. depending on which of these vaccines, if any, succeeds, I see this becoming a major part of any future pandemic preparedness. Is we need a coronavirus platform that can be ramped up, maybe not quite as fast as the flu vaccine, because with that, I mean, you've already got the production lines and the machines and the people and everything doing this every darn year, but pretty quickly, so you could get to a vaccine in 4 or 5 months instead of a year, and that could make a huge difference the next time.
Yeah, I mean, so Moderna would say that theirs is the platform, but we don't know. It could be multiple platforms. We'll have to see what works. But I do agree that has to be engineered so that we can respond quickly in the future.
Yeah.
But I also think we should make some antivirals that are hitting all of these polymerase.
And while we're at
Absolutely.
it, go and look at the other list of viruses that people in the pandemic preparedness field have been talking about for years and say,
for sure.
Maybe we ought to look at Nipah and Hendra a little more closely, and what else is out there?
Well, remember that there are SARS-like viruses in bats elsewhere than China, and we know MERS came out of the Middle Eastern bats, and many other countries harbor their bat populations. We need to know and do more.
We need to do these surveys.
So, in fact, next week on TWiV, Simon Anthony here, who does bat sampling in other countries, is going to talk about what they've found there. So, check that out. One more thing three more things on this paper I wanted to mention. First, this analysis, they say, shows that pangolins are probably getting viruses from bats, and they're probably not an intermediate between bats and humans. There's no evidence that pangolin infection is a requirement for bat viruses to cross into humans. Right. And so pangolins are out there and they're being infected by bats.
How?
Viruses from bats. I don't know. I don't know anything about pangolin bat ecology.
Pangolins are anteaters, basically. They eat termites. They have big, long, sticky tongues.
They're termites close
how
to
in the
bat
hell?
caves, right?
Yeah, so they're rooting around on the ground near the bat cave, and they're going to inhale some guano.
Yeah, one can imagine.
Yeah.
The other aspect that's interesting is that this. All right. First of all, a lot of this sampling was done in collaboration with EcoHealth Alliance, whose funding was terminated, and you see now how important it is. And so again, to reiterate, the termination of their funding was completely wrong. Don't know why that can't be reversed. But they sampled all throughout China. They have southern China, they have northern China, northwestern, and they actually show that some of these recombination events occur across the divergent geographical bat populations. Quite interesting. So this one virus is a recombinant of northern, central, and southern viruses, while two others are recombinant regions from southern and central. So that's really interesting because bats don't have a huge range, right, Dixon?
Well, some do and some don't.
Yeah,
some migrate. Some of the fruit bats migrate thousands of miles, by the way. So they have to because the fruit doesn't.
These are not fruit bats.
The whole time,
these are not fruit bats. Remember, these are insectivorous bats.
All of them?
These are horseshoe bats, right?
Various species of horseshoe bats. I see. Okay.
Yeah.
All right.
So they are, but I think there's a difference in bat range. Okay, we'll have a bat person on at some point.
Yeah, I was under the impression they had pretty big ranges.
Well, some do, but not all.
Sure. Some do and not all. That's right.
And to get an effect like this over a period of several centuries, you'd really only need one bat to go to the edge of the territory of another bat.
Of course.
So
I mean, like somebody migrating to Texas and then going to a COVID party or something like that. I see what you mean. I got you. I got it.
All right. So then the last issue is when? When did this happen? How long have these viruses been circulating? So what's the time to the most recent existence of an ancestor? So to do that, they have all these sequences, and they can calculate molecular clocks, and they can calibrate them using the human coronaviruses that have been circulating for a while, and the changes in their genomes, and also the MERS and the SARS like coronaviruses. So here we go. They have 3 different approaches for estimating the divergence time. The most conservative approach, number 1, the divergence time estimate for SARS-CoV-2 and RATG13 is 1969. So SARS-CoV-2 an ancestor of SARS-CoV-2 and RATG13 is circulating in 1969. And I'm not even thinking about viruses back then.
No.
I certainly wasn't.
I definitely wasn't.
And
No.
1969, HIV is already percolating unbeknownst throughout the human population.
That's right.
Even though we didn't catch it clinically until the 1980s.
Right.
So that's one. While that between SARS-CoV, number one, and its most closely related bat sequence is 1962.
Wow.
All right. And then we have
and the range on these goes further. It could have been 1930s that these things were at.
So the 1969 goes from 1930 to 2000, right?
Yeah.
Right. So it's a big range, and that could be better calibrated with more samples. We don't have a lot of samples.
Right. So the big difference between now and the past is that now, assuming we have a vaccine, that when this thing jumps into humans again, which it's gonna do, we don't know how that happened before, but it's going to happen again, right?
Well, another version, yeah.
And this time we have a mechanism for controlling the infection in humans.
Well, the same virus is not going to jump again. I mean, if it did, it's going to be controlled by whatever we end up making in terms of.
Well, that's what I'm saying. It's exactly
what will happen. It will be a different SARS-like coronavirus will come with a different spike that is not neutralized by antibodies to SARS-CoV-2, and that will cause another.
Yeah. What about the ones that are already in the vats, though? What happens to those? The ones that you're describing right now.
They're lurking, Dixon.
That's exactly what I'm saying. So that they could easily get into human populations in various places throughout China.
Of course.
Sure.
Of course.
So, but when that happens now, you can contain it.
Well, post-vaccine, right. So what you're saying is
post-vaccine.
There could still be spillover events of SARS-CoV-2 original from bats to humans.
Here.
But if they're vaccinated, or if their contacts are vaccinated, or if anybody's vaccinated, this is not going to get very far.
That's exactly right.
Yeah.
And there might also be some spillovers that just don't get very far.
Yes.
There might be a person who comes in contact with a bat, gets infected, dies of sort of unexplained pneumonia, but doesn't transmit to anyone else. And so this virus may have popped into humans a few times.
Exactly.
Not leading to a pandemic, but we got very unlucky this time.
I mean, I'm thinking about the resurgence of Ebola, the resurgence of, Lassa. Those viruses are always going to be there too, but they know what to do about them now, at least.
Yeah. But remember, Dixon, when Peter Daszak, he was talking about serological studies where they looked at people living in the countryside where there are bats, and a few percent of them had antibodies, cross-reactive antibodies to, bat SARS-like virus. So they are being infected, but it doesn't go anywhere most of the time, right?
Right.
All right. So then the two other methods that they used, they get divergence times for SARS-CoV-2 of 1982 and 1948. So it goes all the way back to 1948, which goes from 1879 to 1999, and then 1952 for SARS and its closest known bat relative.
So that doesn't tell you exactly when this particular virus arose, but it does, if I understand this correctly, suggest that it could have arisen decades ago and been cooking in bats for a long period of time before actually spilling over into humans.
Yeah,
right?
And that would be different because there's a certain mutation rate per year per genome, right? So it would be different from the one that's around today. But its ancestor, is around for a long time, for sure.
Rich conjured up a Shakespearean image of three witches and a gigantic cauldron with bats and newts.
All right, so here's another important conclusion. The estimated divergence times for the pangolin virus most closely related to SARS-CoV-2 RITG13 lineage, right? This one that was just isolated recently, range from 1851 to 1877, indicating that these lineages were acquired from bat viruses divergent to those that gave rise to SARS-CoV-2. So the pangolin is not a ancestor of SARS-CoV-2, very clearly. Very clearly.
Nor is the pangolin virus.
What did I say, the pangolin?
Nor do pangolins come from bats.
And it, from what I can tell, it is not necessary to postulate an intermediate host.
No, it's not.
No.
Okay. This clearly could have come directly from bats.
Yes, could have. Now, here in the discussion, a very important paragraph. Given what was known about the origins of SARS, as well as the identification of SARS-like viruses circulating in bats that had binding sites adapted to human receptors, appropriate measures should have been in place for immediate control of outbreaks of novel coronaviruses.
That's in the first paragraph of the discussion, and I actually really liked that whole paragraph talking about trying to identify outbreaks early is important, and we may allow for containment. Earlier they say, for the current pandemic, novel pathogen identification delivered on its promise with viral identification and rapid genomic analysis, providing sequencing confirmation. Unfortunately, a response that would achieve containment was not possible.
The key to successful surveillance is knowing which viruses to look for and prioritizing those that can readily infect humans. Absolutely. You can't find everything, right? You have to know the ones. And we knew for SARS, these bat viruses had the ability to infect human cells. So that's what you look for. I mean, it's a very basic thing, but if it can't infect a human cell, I don't think you ought to worry about it.
So do you think WHO is going to reorganize a little bit and include some other? No. All right. Stop me in my tracks if you want. But WHO right now is in charge of influenza, correct? They've got their network. They've got their people set up around the world. They'll know exactly when an outbreak occurs. Why can't the same thing be done for all these other viral infections? I mean, I don't get it.
In a word, money.
And
in another word, politics.
Really, science and politics? You think those are connected somehow?
The WHO is in a tough spot.
We just withdrew support, right?
There's that, but on top of that, they have an almost federalist system where their regional offices are kings, and their central office is just saying, "Please do this." So it's a bit like the UN in the sense that there's a lot that they would like to do and that would be good for them to do and would make sense for them to do, and they'll try. And then things don't necessarily get all the way down to the deck plates. So yes, the WHO should be on this. An organization that's more likely to be on this is CDC. And the CDC homologs that have developed in other nations, including China, including the EU, to monitor this sort of thing. I will point out that basically this paragraph is saying with what we knew about SARS, we could have been a whole lot better prepared and monitored this and seen this coming. And on a certain level, some countries did. Countries that had a direct experience with SARS responded a lot better than countries that didn't have that experience. And I'm thinking of South Korea here, where they saw SARS-like coronavirus and they said, okay, we've got a plan for that. And they did, and they implemented it. And they've still got that low level of, risk going on, and they can't fully, they've had a few little flare-ups. So like everybody else, they're kind of stuck in this position where they're still waiting for a vaccine to be able to really reopen. But they were able to control things a whole lot better because they saw it coming. All
right. So if you got anything out of this, here's what to remember. Viruses related to SARS-CoV-2 have been circulating in horseshoe bats for many decades. Okay? They've been around a long time. We didn't know them. We didn't pick them up. Now we know it. Cool paper.
Yeah. Very cool
stuff. All right. Rich, take that first one, please. Email.
Cool. Matt writes, "Hi, TWiV. I have loved your zeal for rapid testing since Michael Minnick came on TWiV 640, but a slight clarification on one point. In TWiV 647, Rich talked about the Abbott ID Now and said it uses LAMP. That is incorrect. The isothermal method the ID Now uses is called NEAR, which stands for Nicking Enzyme Amplification Reaction. As Abbott uses it, NEAR uses a pair of primers which introduce a recognition site for a nicking enzyme, and their mix has that nicking enzyme in addition to the DNA polymerase and reverse transcriptase for RNA targets like SARS-CoV-2. LAMP methods currently with an FDA emergency use approval include Sherlock, And he gives dates. I assume that's when the emergency use
when the approval
came in. Sherlock, May 6th. Color, May 18th. CSUN, May 21. And UCSF/Mammoth, July 9th. Figure 2 of the paper in the link below is a nice overview of the various isothermal amplification options, and he gives a link. And that's Matt, who has notes 7 years isothermal amplification and diagnostic. So Matt knows what he's talking about. And mea culpa, yeah, I basically, we had a description of PCR and LAMP. We were discussing LAMP because that's what these firefighters in Racine used, and that's all correct. But because I knew that ID now uses an isothermal method, I just made the assumption, turning out to be unwarranted, that it was using LAMP, and that is not correct. Okay, it uses a different method. And so thank you very much, Matt. And I looked at this paper, and I'm not going to go into it in any detail, but it's great. It's a review from 2011 that discusses all of the various isothermal methods available at the time. And, you know, I don't know if I'm fabricating this memory or if it's really true, but I think somewhere in my consciousness, I was probably aware that there was more than one way to skin this cat. And it turns out that there are at least half a dozen different ways of doing isothermal amplification. And this outlines them very well. They're all head benders. Okay. They're very difficult to understand, but there are many different ways of doing it, and I appreciate that. Okay.
So all of these are, you don't need a thermal cycler. They're done at one temperature. You do need some equipment, though. You do need some kind of a heating block and so forth. So it's not the Michael Mina, but they're better than the typical PCR test.
Right. And they are likely to have the machines, I assume, have some sort of detection system along with them as well. Right. Okay, so it's more than just an incubator. Now, one of the things that I got out of this paper that I really liked, I mean, we highlighted a couple of things when we talked about LAMP before, about how basically the high temperature that's used to melt is replaced by some sort of, they generalize in this paper, some sort of enzyme. Okay. In the case of LAMP, it's a strand displacing DNA polymerase, but it could be a helicase or other enzymes that will facilitate strand separation so that you don't have to raise the temperature to melt it. And that's one of the things that allows you to do a reaction at one temperature. But he points out, and this is cool, that these isothermal reactions are asynchronous. Okay. That is, once it gets rolling, okay, a bunch of individual reactions are happening at the same time, whereas the thermocycler, because you go through these cycles, is a synchronous thing, and the asynchronous reaction is a lot quicker. Okay, the fact that you have to alternate the temperatures and stuff takes time. Okay, so these asynchronous reactions generate a lot more nucleic acid and typically can be done in less than 20 minutes. So that makes the machines a lot quicker.
So, theoretical idea here. A little LAMP machine, right? I don't know how much they cost, but they're easy to operate.
It's an incubator.
Could a school have a couple of them and crank through checking students, or is that not in the cards?
Well, there's another interesting paragraph from this 2011 paper that I really appreciate, okay? Because I think we have a tendency as, speaking for myself, relatively naive to the industry to sort of oversimplify what can be done. And there's this great sentence in this paper that says, under the United States Clinical Laboratory Improvement Amendments, CLIA, clinical diagnostic tests are categorized as high complexity, moderate complexity, or WAVE. Most point-of-care settings, that is, like a school that we're talking about, where you have the machine in the school, only allow use of waved tests that are, quote, so simple and accurate as to render the likelihood of erroneous results by the user negligible.
Yes.
Okay? And it says, currently, there are no waved point-of-care nucleic acid testing systems. Okay. Now, my understanding is that the emergency use authorization for some of the isothermal tests are point of care. But I think there's different types of point of care. I'm not sure. Maybe somebody will write in with this. So I'm a little unsure as to whether these are sufficiently foolproof so that you can install one in a school.
Yeah, the point of care test is you're gonna have somebody spit in a cup, and you're gonna maybe put some drop of something in the cup, and does it change red or blue? I mean, it's got to be
really
simple.
straightforward.
What you really want in that setting is a dipstick.
Yes.
Yep. You want a test where you just dip the thing in and wait some period of time, and if it changes color, it's like the pregnancy test example. You just really want that kind of clarity. If it involves a machine, even under an emergency use authorization, just from the discussions with the local school district here, and we actually have a good local school district. I don't want to say that it's a bad place in that regard, but I don't see this type of thing getting put into place at all. But if you have a test that can be done in 20 minutes, then you could just take a spit sample from every kid and send them over to the lab, which is down the street. There's a medical lab. Every town's got some local Quest diagnostics facility that your doctor sends you to, and just ship them all over there. And by lunchtime, you've got your results on the computer. And if anybody came up positive, you know it.
Right.
It makes me think that the serology survey, now this is a different test. We're talking about serology, but it's still a test. The serology survey that was done in New York, in
Corona,
right? That was done. That was done out of a chain of, emergency. I don't know what you call them, doc in a box, right?
Yeah.
Urgent care.
What?
Urgent care.
Urgent care. Okay, so theoretically, it seems to me now. Once again, I'm making this up because I'm naive about this, but it seems to me that theoretically, most towns have lots of these sorts of urgent care facilities, and that would be a likely place to be able to set up some sort of instrument that you can process tests in.
By the way,
I think the antibody tests are going to be much more likely. The serological or antibody-based tests that you could turn into a dipstick are going to be much easier.
By the way, Dixon, last time we said, Queen of Corona, you said Simon and Garfunkel, but it's actually just
Garfunkel.
Paul Simon.
Just Simon.
Someone actually
Simon.
wrote.
You're right. I misspeak a lot.
No, I didn't correct you either. I'm just saying someone corrected us. So there you go.
At any rate,
it's true.
I want to thank Matt for this, for calling us out. And correcting
for sure.
correcting an error and turning us on to a deeper insight.
Very good
stuff. Appreciate that.
Good stuff. Brianne, please.
Sure. Sawerin writes, Dear TWiV Collective, while listening to episode 645, a comment by Brianne and Rich on interpretations of detecting Flower and Rich's DNA triggered a memory, which then also begat a question. So the memory. Back in the day when unbiased next-generation sequencing was just taking off, I was working in a 50-year-old research building and decided to have a bash at the technology by sequencing some clinical samples and environmental swabs from around the lab. The data that came back was a surprise to me. In among all of the human DNA and other more pedestrian sequences, there were a few signals for HIV prophage, various caterpillar viruses, and vaccinia virus, to name a few. When looking more closely at the sequences, it became apparent that they all aligned on top of each other in very defined sections of the virus genomes, suggesting what we had sequenced were either PCR or cloning products or expression vectors. Now, none of the clinical samples were expected to have these viruses, nor did our lab work with such organisms. And this is where working in an old, creaky research building comes into play. While our samples should not have contained these viruses, and we did not work with them ourselves, previous tenants in the lab, The other labs on the floor and the one below it had in the past 15 years worked with HIV, lentivirus expression vectors, and vaccinia-based vaccine research. So what we had unwittingly sequenced was the work history of the building. The point is this: DNA contamination, especially the amplified fragment kind, is very hard to get rid of. And that is why the gold standard for diagnostic PCR workflows involve unidirectionally physically isolated workflow areas from clean reagent rooms all the way to dirty post-amplification rooms. Now my question. The presence of RNA in various bodily sites, fluids, has been an oft-discussed point of distinction from actual virus on TWiV over the years, only made more prominent by the current SARS-CoV-2 diagnostic dilemmas. But where is this orphan viral RNA coming from? The general dogma of RNA is that it is fragile and easily destroyed, so one could imagine that naked viral RNA in stool, blood, respiratory mucus would get quickly degraded. However, this does not appear to be the case. So is there a reservoir of viral persistence that slowly ticks away, dribbling out RNA, or is there a more interesting fundamental mechanism at play waiting to be discovered? Regards from our wintry 20C, and so far COVID-19 spared Queensland, Severin. From Australia.
Who is a senior research fellow at the Australian Centre for Ecogenomics at the University of Queensland.
I think this is a very good question.
It is.
I don't know if there's low-level replication or not, or if in body fluids, maybe RNA. I mean, first of all, it's not intact RNA, most likely. It's just bits. Mm-hmm. What do we call it? We use some interesting words, which
I call it litter.
Litter, RNA litter. Which persists in fluids, but not on a bench top, Who knows? It's a good question.
But just this notion that RNA is fragile, which I was certainly beaten into me in graduate school when I was working on an RNA virus. Oh, RNA, it degrades when you look at it. Be very, very careful. That is true when you're working in a laboratory, when people are pipetting RNase into their mini preps to get rid of the RNA, and they're scattering RNase, which is a durable, very effective enzyme all over the lab for decades. RNA breaks down real easily in that environment. But out in nature, considering that one of the leading hypotheses for the origin of life is the RNA world, and when you look at the structure of RNA molecules, how they fold up into these tertiary structures that can do all these complex enzymatic tasks, to lump all RNA as a molecule into one category and say that it's fragile just doesn't make a lot of sense to me. If it's out in the world, or in the body, some of it's going to get broken down. But the idea that fragments and litter, as Rich says, are surviving enough to be amplified, I find that very plausible, and I don't think it's anywhere near as fragile in those contexts as people may have been led to believe.
Yeah,
I agree. Go ahead.
Once upon a time on a past episode of TWiV, I don't really recall which episode, but someone mentioned that there might be evidence of something like this happening for other RNA viruses, that RNA may be persisting in people for longer with a number of RNA viruses. We just haven't really studied any of them in as much depth as we are studying the persistence of RNA here. So there may be something really interesting about RNA persisting that I think could be interesting to know about.
Yeah.
RNA also exists in cells as ribonuclear protein particles.
Yeah.
Okay. So it's not just naked RNA on the bench or in a test tube. So I agree with what Alan's saying. But the bottom line is we do not know the answer to your question. I mean, it could be that there's some so low level of virus replication, and that's an important question. But from what we know, it takes a higher virus load to confer transmissibility.
And as Brianne just pointed out, we don't know if it does turn out that there's some low level of viral RNA replication going on and that it's being produced consistently in some people. We don't know if that's anything to worry about or even if that's weird.
Yeah, we don't know if it's special.
we haven't looked at other viruses in this level of detail, as you just said.
So we've previously talked about this happening in Ebola virus infections and Zika virus infections. So we're beginning to recognize this as our detection methods become really good. and we get more and more human infections. But, in the old days when we just measured virus by infectivity, we never saw it because there's no
So,
infectious
Vincent,
virus.
they just revived a 100-million-year-old microbial community from a sediment that they isolated from the bottom of the ocean, as I recall. I wonder if any of them have any phage RNA viruses in them.
Sure, I bet they do.
I mean, to make something that old,
it
start
could
to replicate again, it's quite amazing, I think. Just astounding.
So, and I really love the story here about recovering DNA from all of these
it's great.
Creatures around the laboratory. I had a similar experience that I've related on TWiV before where I was sequencing a bit, and when I did the assembly, wound up forming a contig that went beyond the contig I was sequencing, and it picked up sequences from across the bench.
Yeah,
and you hear Vincent and I say this now and then that DNA is really a problem.
Yeah,
it's everywhere. Okay, that's a quote from a episode many years ago with Eric Delwart. That's a quote of Eric Delwart.
It's when we traveled back then.
Yeah, that was great.
Dixon, can you take the next one, please?
Happy to do it. Kathy writes, hello, Vincent, Rich, Kathy, Brianne, Dixon, and Alan. I think of you all as the mighty TWiVers. Greetings from Seattle, where it is currently 18 degrees Celsius at 9 a.m. We don't get a long summer here in the Pacific Northwest, but right now it's beautiful, sunny, and going to be warm. And when summer comes and the rains dry up, it reminds us all of why we are all alive here. Or why we all live here, too. I added that myself. Vincent was talking about the TWiV masks and merchandise, so I thought I'd send you a silly picture since I have 2 sweatshirts, 2 masks, and a mug. Somebody just moved this for me here. Thank you. Someone's editing as I'm talking.
Sorry.
That's okay. I'm
just
happy
a little paste.
That's fine. I move slowly here. I am happy to support you guys because I get endless joy, knowledge, and entertainment listening to TWiV and your other podcasts almost daily. I am myself a former chemist and retired last year from engineering IT. Although I have to admit that I'm a frustrated doctor as I love medicine, and I am kicking myself for not going to medical school when I had the chance. Long story. At any rate, you guys have rekindled in me my love of science, and now I'm reminded of how much I loved microbiology when I was in college. It never occurred to me to enter virology as a field, but after taking Vincent's awesome virology class online, it's making me want to consider, at 61, to go to graduate school and become unretired. Lots of luck. I'm also nearly blind as a bat from a genetic retinal disorder. Sadly, I am not one of those who can do echolocation. So I doubt that that's going to happen, but maybe in the next life. My next door neighbor is a retired infectious disease microbiologist, and so we regularly nerd out on all things SARS-CoV-2, Nipah, dengue, and whatever topic. Life is for learning, and thank you all for helping me continue to do that. Thank you also for the laughter and for being a bright light of knowledge in a world where disinformation and anti-think is so prevalent. Peace and be well, Kathy. And she sends a picture of herself with her mask on, holding her TWiV cup, wearing her TWiV sweatshirt.
Great.
Excellent.
That's fabulous.
Yeah, she looks very happy. It's cool.
She looks very, very happy.
Well, the writing is
that's
happy.
A charming, touching email. Thank you for letting me read that, by the way.
This is a person, I thought you would like that. This is a person who seems happy. That's great. You skipped her where she writes, I'm still waiting for that countering a miasma of anti-think t-shirt. Hint, hint. Yeah, we're going to make one. We're making a TWiV t-shirt with countering a miasma of anti-think. Wouldn't that be cool? Yes.
That's good.
What? Come on.
And we're also making a masks are cool t-shirt, because Daniel mentioned that last week. Masks are cool is a takeoff from bow ties are cool, which came from Doctor Who, and we're going to have a TWiV t-shirt with masks are cool on it. So yes, that is so cool, Kathy.
Well, Max, in some circles, masks are becoming cool and cooler.
That's right.
What's your mask like? Becomes a fashion statement.
That's right.
That's
good.
That mug is very nice looking. I didn't know they had dark interiors. Cool. Very nice.
Did we have a letter from last time that we'd saved for Alan?
Yeah.
Ooh.
Where is it?
Uh-oh.
Yeah, we did.
Screw up this time.
No, you didn't screw anything up.
Anything.
Nothing.
Let me get it here because it's a good one, and I will paste it in, right? Because I was going to have him go next, but so that's last week, yes. Dixon.
Someone wanted advice, and we thought you would be the best to give it.
TWiV archive. So that would have been, was that Wednesday, Brianne?
I think it was even before that.
I think it was maybe last Friday.
It was last Friday.
Oh, that's
It was
after
after
Dixon.
Alan left last Friday.
Last Friday after I left.
Yeah, you just missed it.
Well, let's get the next cycle. I don't want to keep us waiting. Why don't you read this one, Alan, and I'll find it. Go ahead.
Anonymous writes, on TWiV 644, you expressed frustration that Pfizer or BioNTech was testing a vaccine candidate that contained only the receptor domain of the SARS-CoV-2 spike protein rather than the entire spike or other viral proteins. I just wanted to note that that Pfizer-BioNTech's strategy actually involved testing 4 different RNA-based vaccine candidates, 2 encoding just the spike receptor binding domain and 2 encoding the full-length spike. On the show, you were talking about preliminary results for BNT162b1, which does just encode the receptor binding domain, but BN216-2b2, ask your doctor about, is also currently in trials, and it encodes the full-length spike protein. Plan seems to be that they will evaluate antibody and T-cell responses in phase 1 and 2 trials, and based on those results, one of those 2 candidates will move forward to a phase 3 trial. I'm not sure the status of the other 2 candidates, but I believe they are also in human trials. And below are a couple of sites with information on these vaccine candidates, along with an excerpt with some of the key details, and sends a couple of links and the excerpts.
But down below the second bit of dashed lines. So Pfizer.
Yes.
Okay. Read that.
So then just a quick follow-up to this to mention that Pfizer-BioNTech has selected BNT162b2, which encodes full-length spike protein, to move forward into phase 2-3 trial. 162b1, which encodes just the receptor binding domain, does not appear likely to be tested in a phase 2 or 3 trial, or combined 2-3 trial, although they will continue to collect data from the phase 1-2 trials of all 4 of their vaccine candidates. Link to the press release with more details on the rationale for choosing 162b2.
And I read the press release, and the rationale is that it did better.
It did better, right?
Okay. I think they were listening to TWiV.
Yep. I got a few emails about this because we were complaining that why would you do just the receptor binding domain? It doesn't make sense. Do the whole spike. So they are, and that's good. Do you have time to address
I have
one?
time, yes. So I've got 5 minutes, and I see this.
I put Jess in. Go ahead.
Wrote, hi, TWiV team. Per the most recent episode about science writers and journal preprints, I'm curious about the route one follows to become a science writer. That's been one of my favorite parts of my career in science, is how to repackage science for general consumption, but I don't know how to end up in a career doing that. Any ideas, Alan? Thanks, as always, for your podcast for disseminating scientific information in an equally effective medium. Okay, Jess, I would advise, first of all, marry well. And that's, that is advice that I myself have followed.
Charles Darwin thought that way too, by the way, so you're in good company.
It has made a tremendous difference in my career. Because I work as a freelance science journalist, my income is irregular and not guaranteed in any way. And it is very, very important to have a spouse who is going to hold down a steady job and, have the steady income that can actually support something like owning a house. So other than that, and also, somebody you like is a good thing, which I really, really hit the jackpot on that. But other than that, I would advise you to, you don't mention if you're in graduate school or what at this point. If you're in a graduate program working on a science degree, great. Pursue that, and I would say you probably ought to complete whatever it is you're in right now. You may look into journalism school if you're at a transition point where that makes sense. There are a couple of great programs in science journalism, particularly at the master's level. NYU has one. I'm biased. I used to be an adjunct faculty member there, but the director of that program is a Pulitzer Prize winner, and it's a really good program. It's called SHRP. There's another program, I believe, at Columbia University, and there's one at, I think, UC Santa Cruz. One of the UC schools has a science journalism program. There are a couple of others scattered around the country too. These are the ones I know about just off the top of my head. Look into those, give it consideration, and it would be a couple of years of your life and paying some money up front for tuition and that kind of thing. The payoff for that is that you will meet a lot of people who will be working in your career, and you will also learn in a very compressed setting a whole lot of journalism that takes longer to figure out if you just declare yourself a science journalist and go out and do it, which was the path I took. Once I started teaching journalism and seeing what the students were learning, I said, wow, gosh, I wish somebody told me that earlier. So you'll learn things like video and audio production, again, in a much faster setting than you would if you're just blundering around figuring it out from YouTube videos. So that is definitely a path that I would recommend. It is also possible to just declare yourself a science writer and start pitching stories. In the current environment, I certainly don't recommend that, but it can be done. And if you're going to do that, well, best of luck.
So, Alan, you actually started out with internships. Is that correct?
Yes. So what I did while I was finishing up my doctoral work in Vincent's lab, he was very generous with with allowing me to spend half days downtown in the nature offices.
What?
Yep.
So that's where you were.
Either that, or maybe I didn't mention it to him.
I thought you were in the cold room all that time.
Yeah.
I thought it was once a week. That's all.
Basically, while I was revising my thesis, I was spending some time down in the nature offices as an editorial intern. And that was actually a paid position. I believe they still do that. They still have editorial internships in the nature offices. You'll need to obviously wait until people are going into the nature offices and interns are a thing again. Mm-hmm. So that's like 2021 sometime maybe. But that was a great foot in the door there, especially coming from the background I did, because then I was working at a scientific journal in an environment that I understood on that level, and was able to kind of pick up the journalism side, initially writing press releases for papers that they were going to put out, and then writing short news briefs. And then eventually I parlayed that into a freelance career where I was, my first client was in fact Nature Medicine, which was one of the journals in that office that I'd had contact with. So that can help a lot. I don't know that route is necessarily going to work out so well, as I say, in the current publishing environment, but it's worth a try if you're situated in a position where you can do that. All
right. Thank you, Alan.
And with that, I am going to go ahead and check out. I see Dixon has left, but bye, everybody.
Bye. Good to see you, Alan.
Alan Dove is at alandove.com, Alan Dove on Twitter. No, I'm sorry, turbidblack.com and Alan Dove on Twitter. Thank you very much, Alan. See you next week.
Thank you. It's always a pleasure.
Bye-bye. This journalism program at Columbia, Jonathan Weiner is a professor there. He's got a Pulitzer Prize. It seems to be a requirement for being in a good journalism program. And I teach a lecture in his course every year, which is on science writing. And the students, they all end up contacting me years later, and they've got jobs, and they're writing stories. And so I think that's a great way. As he said, you meet people, and that's really important.
We need good science writers.
We do.
Yeah.
All right, that brings us to me. And the next one is from Wayne, who writes, Hi, TWivers of Truth. 36C here and raining and mosquitoes galore. Another email from Japan. Sorry for so many, but TWiV is a life savior for me. The amount of bogus information out there on COVID is off the charts. Don't worry, it's okay. You can send as many as you want. Back episodes ago, Dr. Condit commented on how exhaled breath can be seen in winter, something I teach my English students here in Japan on the importance of wearing a mask. I found this photo that illustrates the exhaled air and the importance of wearing a mask, using cold air to show the importance of masks.
It's fantastic.
Nice picture. No masks,
It's
two people facing
perfect.
each other, the breaths coming out. One mask, one person is not exhaling, and then two masks, neither one. It's beautiful. And it says at the bottom, now do you get it?
What part of this don't you understand?
And of course, we have a haiku from Wayne. The rain of truth leaves now shimmering, washed clean.
Oh, my.
From Wakayama, Japan. Lovely.
Excellent. Thank you.
Rich.
Where's Yakima?
Yakawama? What? Wakayama?
Wakayama. Where is Wakayama? Which island is that on, by the way?
Don't know.
I'm looking it up, dude. I'm looking it up.
Okay.
Wakayama is a city in Japan's central Kansai region. Do you know the Kansai region?
That doesn't help.
You
Which is it on the big island?
It's right next to Osaka. Right next to Osaka.
Oh, that's better. Yeah, I know.
Which is not far from Kyoto.
Kyoto.
Main island,
Thank
yeah.
you. Thank you.
Okay, Rich.
Igor writes, hello, TWivers. Thank you for your work. I'm a physicist at UC Davis, and I've been following TWiV since episode 601 with Christian Drosten. I moved to California from Germany last year and have been listening to each episode of Drosten's Das Coronavirus Update, which is extremely informative, but less fun than TWiV. Since Das Coronavirus Update is currently on vacation, you have become my primary source of reliable information. Now, coming to stool, which was discussed in TWiV 645 again. According to this Nature paper, co-authored by Drosten, gives a link, figure 1, viral RNA is present in high concentration in stool over 3 weeks after infection, but it is negative in culture. So stool is fortunately not infectious. I think this is important information for cleaning personnel. I was very excited by TWiV 640 with Michael Minna. That was the one on rapid testing. I hope the UC system will start working hard in this direction to implement widespread and frequent antigen testing. Cases are increasing. We need it. Great thanks to you, Drosten, and the other great virologists that enlightened the darkness. Best, Igor.
Hey, we don't take a vacation here on TWiV.
Yeah, I was going to say, what's a vacation?
Somebody want to spell that?
Dixon, you can take a vacation, but you get docked.
So
I think
I wouldn't rule out the possibility of virus in stool.
Right.
Okay.
Infectious virus, you mean, yeah.
I think there's actually at least anecdotal evidence of transmission from species of this and other coronaviruses. I wouldn't be surprised if the ratio of infectivity to quantum of RNA is lower in stool than elsewhere, but I wouldn't rule out the possibility.
I thought SARS-CoV-1 had some clear evidence that it was transmitted by stool. Yeah.
Fecal plumes from flushed toilets with the plumbing modified. They took out the traps.
By the way, I have a solution to that person's concerns. Flush while you're sitting on it, and then don't get up until it's finished.
TMI, Dixon. This paper he cites, we actually did a long time ago here on TWiV, and if I remember, these were mild symptoms patients, and he speculates that maybe people with more serious COVID, maybe they would shed infectious virus. We just don't know. I think you shouldn't rule it out. Yes, but it does seem to be low.
But all these things are relative. We're not talking black and white. We're talking gray. And
Here.
My current understanding is that the biggest hazard is droplets.
Yeah,
okay?
By far.
Brienne, can you go next?
Sure. Tony writes, I like the Q&A portion of TWiV. I have a question I've not seen addressed elsewhere. What do you, as experts, think of the possibility of mass immunization via semi-controlled exposures, e.g. pox parties, for the coronavirus, given that the level of exposure seems to dictate severity of later infection? I have my suspicion that once the public has a better understanding of the epidemiological facts of the virus and increased lockdown fatigue, it will become fashionable to become infected, to get back to work and play, and to protect one's children. Thanks. I think that's a really bad idea.
Here. That's a very, very bad idea.
I think that people sometimes forget that it's not just you live or you sort of live with no big deal or you die of this virus. There are a lot of really severe complications and maybe some sort of long-term things that happen to people after infection. And I don't know that we want to induce some of those things on purpose.
Nope.
Plus, as I don't think there's evidence that the level of exposure dictates the severity of it.
Not at all.
So, so it's really a matter of who you are. And if I'm not mistaken, there was a story not too long ago, fairly recently, about somebody getting coronavirus from a coronavirus party and dying.
Mm-hmm.
Okay?
Yes, I've heard that story.
This will, it's sneaky because a lot of people, myself included, I've not been close to anybody yet who's had the disease. Okay.
Yeah.
But people are dying from this, and the health system is getting overwhelmed. So this is a dangerous virus.
As Daniel Griffin says, COVID kills.
Yeah.
A couple of weeks ago, he told a story of a patient in the 50s who came in, went into a coma, and woke up to find that their legs and fingers had to be amputated.
Yes. And
he used that as an example of saying, are you serious about challenge experiments? Who's going to tell this person after they are in the control arm and they get this and they wake up and who's going to be responsible for that? So you people thinking about challenges, go away, please. Get out of your mind.
And so who would want to have that outcome after going to some sort of party?
Yeah, exactly. That's right. So this is not a good idea ever. Dixon, you are next.
Rodrigo writes, Dear Vincent and crew, thank you again for all you do. That sort of rhymes, doesn't it? On the subject of Minna's et al. Testing idea, may I suggest that the way forward here is actually for well-placed phone calls in sequence and not necessarily a writing campaign. With summary video on hand, for example, MedCrams, you guys call Fauci, probably a very brief call, or someone that can call him. Fauci calls and explains it to Pence. Pence tells Admiral Guerrero, the guy in charge of testing, to get it done, and it gets done. Considering the staggering clarity of the argument, the simplicity of the test, the side of benefits of school openings, saves economy, etc., this would be a no barrier to everyone and all involved on the call chain. While many causes greatly benefit from active public support, letters to Congress, etc., this seems to me an obvious solution in retrospect to avoid a meteorite that is just about to hit Earth. P.S. It's already hit. There is no need to rally popular support on a newly discovered obvious solution to a monumental threat. With your wherewithal, please find the 4 degrees of separation to be authority in charge and just get it done. With deepest thanks, Rodrigo. Well, it sounds simple, doesn't it? I think it would stop at Pence, I'm afraid it would.
Yeah, there's a link in that chain.
There's a weak, very weak link.
Well, in fact, in our interview with Tony, we said, hey, Michael Minna has this idea of cheap, rapid antigen tests. Can you do it? And he said, well, we're not exactly doing that. We're doing something similar. So basically we had the phone call and he didn't want to pursue it, right?
Well, yeah, maybe.
You remember, Rich?
Yeah, I think, however, I have some confidence that with all the noise that's been made about this and with projects like the Rockefeller Institute and other people making noise about this, that this is on people's radar. Okay. I think that from the point of view of the technology and actually deploying it, it's not as advanced or as simple as we think it is. Okay.
Yes, of course.
But I think that this is likely to catch on. Okay?
By the way, many people are writing saying it can't be done for this reason, that reason, and another reason. I don't care. Just do it.
Exactly.
We're in a war, people. And
Tell me
after
about
every war, during every war, we mobilize. We do things we're amazed that we can do afterwards.
That's
You can do
right.
it here.
That's right.
Don't give me excuses why you can't do it.
You make me.
I totally agree with you.
You make me think. Although this is a different technology. During World War II, we made an atomic bomb from scratch.
Yes, we did.
With only the barest of theory. Okay,
Yes, that's right. And I'm sure there were people who said it wouldn't work, right?
Radar.
Lots of them.
Radar.
Radar's another example.
Many things. Hey,
can do
breaking the
this.
code. The ladies who broke the code in England, right?
You can do
They
that.
all said, you can do it. Don't give me reasons why we can't do it. It's just, this is the one time in your life where you should do stuffing. Figure it out.
Damn right.
That's my turn, I think. Kevin writes, may I suggest that letters should not be restricted to just political leaders? Consider your local news outlets, TV, newspapers, radio. Research the reporters filing the most SARS-CoV-2 stories, communicate with them. Wouldn't it be great if questions about cheap, rapid testing started to be asked at every news conference? Love your podcast. Keep going, please. Yes, I totally agree. I don't just mean elected. Anybody who's visible, you should write to it. A lot of people are. I got more letters in the past week. They're all on the page. I think everyone who goes on TV, I mentioned last time that Ian Lipkin was on CNN and he didn't mention rapid testing. Come on, folks, get with the program. And you know what? The scientists are not listening to us. They're not even listening to each other, not to Michael Minna. Please, this is not about your little agenda. Talk about it.
You can probably do a lot more with your agenda if you could go back to lab and back to work and actually move forward with life.
That's exactly right.
What are you kidding? Don't you enjoy staying at home?
Rich.
There's some parts about it that are nice, but there are also some parts about it that are getting really old.
Tell me about it.
Rich, can you take the next one?
Anonymous writes, hi all. I was hoping you would comment in your podcast about this article that just came across my Twitter feed about a do-it-yourself vaccine that was developed by Preston Estep and taken by at least 20 volunteers, including George Church, he of mammoth cloning fame, and gives a link. I'm not a virologist, immunologist, or someone who studies human disease, but as a scientist, I study permafrost and Arctic ecosystems. This strikes me as reckless, dangerous, and counterproductive. It sounds like there are problems with the basic science of it that I have only limited understanding of, but even without that, some basic questions come to mind. How will they know the effectiveness of the vaccine, its safety? How could it possibly be scaled up to produce hundreds of millions of doses? Have these people ever taken an ethics course or learned anything about experimental design? Would love to hear your thoughts in more detail. I didn't look at this. Did you?
Yeah. Oh my gosh. He's absolutely right. So this is just reckless. What are the things he said? Reckless, dangerous, and counterproductive. Well, it's not very dangerous. It's not going to hurt them, but they don't have anything planned to figure out if it works. They made peptides. They predicted which spike peptides and one other viral protein would be B and T cell peptides. Man, there's a white paper associated with this website. Go look at it. It's pages and pages. These guys didn't have apparently anything else to do but summarize the literature on all these epitopes and how to predict them. And they decided about a dozen peptides they had synthesized. They mixed with crab shell chitin as an adjuvant, and they inhaled it.
Yeah. Yep.
Holy crap.
Along with what? What was the other thing they inhaled?
And so there's no plan. How do they know it works?
A little white powder, perhaps.
There's no clinical. It's just a selfish, self-serving exercise because they can do it. George Church, has hundreds of millions of dollars, too much, and he can screw around. And apparently, someone had the hours and hours. I'm really pissed off about this. Not because I want it. I don't give a crap about this, but it doesn't help anyone because it's not being tested.
That's better than going to wear your mask.
Oh man, I was looking at this last night and I'm going, are you serious? Because George Church is a good scientist. He does good stuff and we've talked about his work. And apparently guy in his lab just, oh geez, that's just no good. No good, folks.
No good at all.
There's no way, even if it's a good idea, I mean, it's a peptide vaccine, which is not horrible, although they've never really worked very well. Yeah, Brianna, if you give people peptides, what would you expect to get? B and T cells, both?
Maybe I'd expect to get some CD8 T cells.
Yeah.
Most likely. I'm not sure that I'd expect to get much in terms of B cells. Definitely not CD4s.
All right. Brianne, can you take the next one?
Sure. Ginny writes, I love TWiV and recommend it to everyone. I contacted my electeds about the 10-minute test. Senator Schumer's office sent me back a form letter about what he's doing about COVID, so I'm not sure they understood. I'll have to try
a form
again.
letter.
Of course.
Dear occupant.
You were talking in 647 about COVID transmission from children. I had seen something on this earlier from the University of Vermont. The sample is very small, but it also references work from other countries, and she gives a link to a news article from the University of Vermont. Even if children don't often transmit SARS-CoV-2, since there are many adults in schools, in my opinion, it's still risky to open schools without the consistent universal testing that Dr. Minna described. Thanks for all you do. Stay safe. And that's Ginny from Rochester.
This is just a very small study which said only 8% the child was an index case. Okay, only in a study of 39 children. So, I mean, it doesn't say they don't transmit. And so, as she says, it's still risky. And we've shown today and last time that there's good evidence that they should transmit. So,
we're going to get a population level experiment.
We are.
In a month or so.
Isn't it so typical? You write to your senator and they tell you what they're doing. No, that's not what I said to you. I want you to do this.
That's right. That's right.
Thank you for your concern.
Maybe you should write to Amy Schumer.
Is that his wife?
It's his daughter.
Oh.
No, she's a
she's an actress. She's a comedian.
Oh, that's right. That's right. What would that do, Dixon?
You might get a better response.
Can you read
get a comedian talking about rapid testing.
No, she's quite serious, though. I think she's just had her first child.
She has.
So,
yeah, she has a pretty big following. Is she really his daughter?
Yeah, absolutely.
I had no idea.
Yep.
Really?
Exactly.
Oh, I didn't know that either. Dixon, can you take the next one? Well,
He's not nearly as funny as she is.
We'll find out if you're right.
Amanda writes, Hi, TWiV team. I'm writing you from Santa Fe, New Mexico, from whence last week's opera letter writers also came, who knew that a tiny town renowned for its arts would have such secret virology enthusiasts. I am only a trained director for the National Weatherization Program located here in Santa Fe. After several months of listening to TWiV, I realized how little I know about viruses, but also how much more I do now compared to my non-TWiV listening friends. Thank you for this wonderful gem of a podcast. My question is about the news yesterday that Dr. Fauci mentioned wearing goggles for added protection against the SARS-CoV-2 virus. The program I train for sends workers into homes to help with energy efficiency measures. There is now very detailed safety guidance for these workers, but one thing that has not been stressed is the wearing of safety goggles. Of course, most of the people doing this work already have safety goggles they may wear to protect themselves from dust, etc., where necessary. Do you think this would be good advice just to have them wear the safety goggles all the time when they're in other people's homes? Thanks again for all your time and expertise, which is why so many of us are benefiting from immensely. Amanda, and you write, Vincent.
So Daniel Griffin says any occupation where you're facing a lot of people, you should wear eye protection. So in his case, he always does, and his nurses and other physicians do, because they're seeing patients constantly. So, even though the number of infected people may be lower, I would say if you're going into 10, 20 homes a day, you should wear eye protection.
Exactly.
But that's channeling Daniel Griffin. Okay, I think it's a good idea.
That's fair enough. Vincent, have you ever been to Santa Fe?
Oh yeah, I used to go often. I like it very
city.
much.
It's actually a gorgeous city.
But there are too many New Yorkers there, frankly. Yeah, I mean, I was
where
walking.
The Georgia O'Keeffe Museum is that right?
Yes, it is.
Oh, it's a lovely little town, but as the locals will say, there are too many tourists. It's really overrun because it's gorgeous. There used to be There used to be science. These Keystone meetings. They used to have them in Santa Fe. So I've been there many times for that. Right. Yeah.
According to Wikipedia, Amy Schumer's father is Chuck Schumer's second cousin.
Oh. Take it all back. I take it all
good.
back.
That's good that we figured it out, that Brianne did, and we didn't have to get yelled at.
Now you can edit.
I'm not going to edit it. It's too much work, Dixon.
Yeah, well, that's going to make me look like a bozo again, right?
This is from Mark. No, Dixon.
No, it makes us look like we actually check our sources.
That's good.
Mark writes, good. Mark here, the electrician from episode 629. I'm sending in a copy of the letter I shared to my county and state officials. I actually got a response and not a copy-paste version, a real email from an actual person who took the time to read what I wrote and looked into the study from Michael Minna. I was blown away and ecstatic. It gives me hope that there's a small chance something can change. Here in Maryland, we seem to have a pretty level-headed Governor Hogan and open to new ideas to get things moving again. I'm hoping that the study from Michael will be able to reach him and our public health officials. Fingers crossed. So then he praises us, and he says, in TWiV 629, Alan, Vincent, and Dixon read my letter and told me to keep spreading the information I have to my fellow laymen, construction workers, and veterans, since I'm not in the ivory tower and may have a platform of sorts, given that my wife is an immunologist and helps me translate/understand. OMG, was this wrong? LOL. It's amazing. Some of these people are so far gone. I've been able to get through to a few of them, which is good. But the majority say I'm just part of the narrative and agenda creating more brainwashed sheep in America. Hopefully, it at least gets them to think a little or start to doubt what they think they know. Anyway, here's the letter to my officials. Be gentle. So he gives a copy of his letter, which I'll put on the letters page. So thank you, Mark, the electrician, for doing this. It's really great.
Absolutely.
His last line is, I'm writing this to you with no political agenda, just as a concerned citizen trying to keep up with the science.
It's a wonderfully written letter, too.
Beautiful. Very nice.
Very nicely done.
Brianne.
Yes. James writes, hello, TWiV. Really love the show. I'm wondering if you can talk about how the phase 3 vaccine trials, Pfizer, Moderna, etc., are designed. Specifically, how do they control for the random exposures out in the world between the two treatment groups? I'm guessing that the large number of subjects, 30,000, provides enough power to overcome this. Thank you. You're exactly right, James. It really is about having large numbers of people waiting long enough and thinking about places where you have a fair number of exposures in the population. So you might not want to do your phase 3 trial in New Zealand where there is little virus, but you might perhaps want to have it in a place where you know there will be some infections in your groups.
Like Texas.
Or Florida.
I was trying not to call them out.
Or Arizona.
Yeah, that's the whole idea. That's one of the reasons you do so many people, is you want to make sure that you get a significant number of people naturally exposed to the virus. And now I think it's important to distinguish that all of the tests up to the phase 3 trial, none of them actually test for whether or not you're protected from disease.
Correct.
They say whether or not you make an antibody response, but we don't know if that's protective. It's not till you get to phase 3 you really get some ideas of whether or not these things actually work.
Right.
And that's based on what type of data you're collecting. And
yes,
sort of
which makes the study longer because, if it's a periodic outbreak of some sort of a disease, then you have to wait for the disease to come along, right? This one's fortunately smoldering all the time. But if you're looking at flu or you're looking at, some other seasonal infections, you'd have to wait, like West Nile, for instance, in the United States.
Rich, did I skip you?
I don't know.
All right, go.
Take
the next one. Take the next. Christian.
I just do what you tell me, Vincent.
Christian.
I'm not keeping track.
You're the only one. You're the only one in the world who listens.
His capsid is still attached to the cell, however.
Dear Twivonians, I have been an avid TWiV listener since the large Ebola outbreak starting in 2014. Mm-hmm. Let me briefly mention that I greatly enjoy the weather reports, and especially the banter during the show. Oh, a true devotee. Obviously, in the current pandemic, I have mostly kept my TWiV listening habits and consumed the excellent info conveyed so clearly, including the recently aired interview with Eugene Koonin, although I'm only a third or so through. As a fellow scientist, I am really impressed how thoughtful he is, and also by the precision of his diction. Yes, diction. Yes, absolutely. Eugene is, you got to listen closely, but it's all there. What I really wanted to ask about was the new testing paradigm. in quotes. As Vincent calls it, I have drunk the Michael Mina Kool-Aid, and I am fully on board with the arguments. However, my experimental scientist experience suggests that although the principle seems completely sound, there could be little devils in the implementation details. Please do not misunderstand this as criticism of the approach. Rather, I was wondering if somebody is looking at running what I may call, as a non-expert in the area, a large-scale trial of the concept. For example, using a rapid test every day on everybody in a certain community that signs up for it. This would help uncover implementation issues, and I am almost certain prove to the doubters that this can be made to work out well. I am not sure what the control would be or how the trial would be evaluated. So these would be interesting points of practice. A trial would also hopefully dispel a possible argument that Mina et al.'s work is only a simulation study, since some people are likely to discredit anything that is not actual data-based, even though the simulation, in my humble opinion, is very sound and straightforward, plus based on solid assumptions that are themselves based on data. Would be great if you could discuss this, and perhaps there are already efforts underway that you are aware of. Keep up the excellent work, Christian. I am not aware of trials like this going on, but I fully anticipate that that's exactly the kind of thing that will be done in the process of, because any screening protocol like this is going to need some sort of regulatory approval. Yeah. And that regulatory approval is going to be based on trials and comparisons with other established technologies, and et cetera. So that's exactly the kind of thing that will be done. And what we can do more than anything else is to apply pressure to, increase the focus on that kind of thing and make sure that it does get done.
Absolutely. It has to be tested. You can't just use it. The FDA won't license it, right, unless it's been tested in some way.
Right. And he says, when I looked up drinking the Kool-Aid on Wikipedia, I saw the phrase often carries a negative connotation. As I recall, that is the mass suicide of a cult. What cult was that?
It was Jim Jones.
Branch Davidians? No.
Branch Davidian?
No.
James Jones, right?
James Jones.
That's right.
Cool.
Branch Davidians were the Waco incident.
Those are different.
Jim Jones, this was in Guyana.
That's right.
Jonestown, right?
Yes.
Right. I think that they drank Kool-Aid basically, right?
He convinced I didn't know all of them knew it was a mass suicide, but he convinced them to participate in this mass suicide with poison that was mixed in with Kool-Aid.
So now the phrase, you drank the Kool-Aid, it's not great, but can have you believe in what someone has said.
Right.
Yep.
But I fully believe in Michael Mina for sure. I think it makes perfect sense. Dixon.
Well, yes. Shri writes, hello, TWiV. I've been hearing about all the new SARS-CoV-2 vaccine candidates being developed at warp speed. What does warp speed actually mean? The NIH website says protocols for the demonstration of safety and efficacy are being aligned, which will allow the trials to proceed more quickly. But aligned is a very broad and nondescriptive term. I'm curious to hear your discussion on the safety/efficacy feature of warp speed. Thanks. And thank you in general for this spectacular podcast. I've been listening since I started grad school 6 years ago and bug all my friends to listen to it too. Shri. So I wrote a little side note, and it says, too bad Spock is no longer with us. He would have given a good summary of the warp concept. Warp
I think McCoy would have been.
McCoy even better. Absolutely.
Wait a minute. No. Yeah, McCoy. He was the engineer, right?
No, he was a doctor.
No, Scotty was the engineer. McCoy was the doctor.
I'm a doctor, damn it.
Yeah, that's right. Scotty would have done it.
Scotty, since he beams you up.
That's right.
Scotty would have done it, but Spock would have done it in a cultured, formal, easy to understand way. At any rate, warp speed means faster than we can go now.
Rich, what is
no question about that. No
Rich, what does warp speed mean? You know,
no, it's faster than the speed of light, and it's just I assume it's faster than the speed of light. I think you're
correct.
I think the idea is you're warping space-time.
It actually stands for things, and I forgot what it stood for. You could look it up on the.
But it is it's
Enterprise.
a pretty. I don't know if Star Trek actually invented the usage of the word for faster than light travel, but that's basically what it is.
There was one Star Trek movie that had the inventor of warp speed, a drunken, broken down engineer.
Yeah,
actually, they rode up with him and saw it work.
I forget the name of the guy. It'll come to me.
In terms of vaccine development, Rich, it just is that it's the process part. The manufacturing is being ramped up to align with the clinical trials, right?
I call it rather than warp speed. And Tony said Tony Fauci said he did not like the name because it implied it carried with it the possible inference of skimping on the safety.
Exactly.
But the way I see it is it's telescoping procedures, overlapping procedures that would otherwise be spread out.
Yeah,
so you hear a lot. Usually you hear phase 1 trial, phase 2 trial, phase 3 trial. Now you're hearing a lot of phase 1/2, phase 2/3. Yeah. They're overlapping the trials. When they get a little bit of good data from one trial, they initiate the next trial. Yep. It's not that they stop the first trial; they'll complete it. And also, I think the big one is scaling up the manufacturing in anticipation of the trial working. So that saves months, if not years. Okay,
but
it puts money at risk, but nothing else. And
whose money though? That's the point.
The government's money at this
exactly.
point.
It's your money and my money.
Oh, it's your Social Security, Dixon. That's what they're spending.
There you go.
That's correct.
So
okay.
I'm confident that all of the safety protocols that are normally in place will be implemented.
I agree.
They'll complete the trials.
Yeah, sure.
That the FDA will be scrupulous about this, and that they won't skimp on that. It's just that it's being compressed.
The problem is, and then we talked about this Wednesday, that wonderful letter from someone who knows about vaccines. So what they're doing in warp speed is starting the manufacturing now before the trials are over. And what that letter writer said is that sometimes the trials inform the final formulation of the product. And that's not possible in this case.
Right.
So it may be that they say we have to change this, but we can't because we've already made it, or at least the first 100 million doses. So that could be a problem. All right. I think, you don't have a choice if you want to, because if you're going to wait for a sequential 1, 2, 3 trial, it's 5 years at least. Yeah. And then you manufacture. So you can't do that obviously now. All right. One more is from Wendy, who says, I'm resending my emails so I don't get Racken yelled at for mailing to his personal e-box because I want to make sure the entire team gets my thanks and recommendations. It's okay. My email, it's not a personal email, but it's out there on the websites. And if people send it, the only problem is if you send it to me, I don't know if it's to me or TWiV, sometimes it's not clear. Also, omitted my weather update outside Denver, where it's actually tolerable. 93F, brown grass, dry heat, Colorado day with a chance of our politically unusual and frustrating Democratic Libertarian governor, possibly but not likely yet, making a needed move towards curbing our rapidly trending numbers, and loud as thunder recently mandated outdoor masking in my county. Yippee. I've concluded that libertarian leadership is an oxymoron. It's all too much. Have your cake and eat it too. No decision making. Colorado has a great economy. It's important and it would be wonderful to maintain that, but I don't know how he thought he'd do so, given predictable in such a countercultural, freedom-driven state without making some clear and politically, economically painful decisions upon reopening. So now we continue to climb. All right. Episode 642, that's 50 keys of spike mRNA. She liked that name. Thanks for bringing Racken yelling to the world, and to all of you for my moment of zen. Well, my long moments. My husband said he didn't know how I could listen or watch repeatedly to 2 hours at a time of variations on the same arcane subject, to which I replied, yeah, it's not like listening to Grateful Dead show or anything, variations on the same song over and over again, accompanied by intense fandom and memorizing arcane data. Boom! So thanks for that opportunity. I just want to say, bub, it's not arcane. It's affecting you right now. Come on. But I think her comeback was beautiful. No more arcane than anything else. And B, my main reason for writing. Have you thought about a line of TWiV chairs? I wonder, as I outfit my daughter's remote schooling setup and actually realized I've been debating between a gaming chair and one that looks like yours and Dixon de Pommiers, I would buy those, and they'd get used both for great back support while watching y'all or the dead on YouTube. I think, I wouldn't have no idea how to make a TWiV chair, but if someone knows, I'd be happy
I think my chair would require too much padding.
See, Brianne, do you have a logo behind your head on that chair?
I do have a logo behind
All
my
right,
head.
so we could just put the TWiV logo there, right?
We could. I actually was thinking when I saw this, I'm like, I could probably get a little cover that could just go over this.
Yeah, it's a TWiV logo on it or whatever. You could put a Drew. They should probably sell them at Drew at the Drew store.
Oh, there you go.
P.S. My daughter and I have had COVID. My husband, no symptoms. My daughter, 12, COVID toe, lightheadedness, vasculitis, and lack of circulation to one foot. Looks similar to Raynaud. Some neuropsychiatric symptoms that had to be treated for a few days, and fatigue. Major symptoms lasted 5 weeks. I had close to 90 days total, the worst only about 2 to 3 weeks of chest, lung pain, SOB, hypoxia, all treated at home because this was early enough that our symptoms were atypical. And even I had a hard time believing the diagnosis, despite understanding much of the sequelae and testing issues. Plus, that was the recommendations at the time. And she goes on to describe, thank you for being a life raft. A heroic effort in just horrifying anti-science, anti-information intellectual climate. PPS, like that great hairstylist who wrote you, that by virtue of demographics, I'm surrounded by conspiracy theorists, amateur astrologists, and anti-vaxxers, maskers, COVID partiers. Again, horrifying, but also sociologically fascinating. Medical anthropologists, sociologists will be dining out on this for a long time. I need my TWiV gaming chair so I can sit back and watch from a distance. Wendy, these are great. Thank you all. Well, they're all great letters. You guys are amazing. Your letters are very nicely written and bring up good questions, and we are honored to read them here.
Have very cool listeners.
It's like every week, it's a party.
Exactly.
Good.
It's a different kind of COVID party.
It is we do have a COVID party here, but we're all sitting alone in our rooms,
That's right.
It's a socially distant, responsible COVID
party. But I've gotten really used to this whole Zoom thing. I don't even think about it. I feel like I'm with you guys.
You are.
It's kind of cool.
Of course, it's been so long since I've been with anybody that I don't know what that's like anymore.
Yeah, I do like the Zoom business. It's cool. All right, that is TWiV 648. You can find the letters and everything we talk about, show notes, microbe.tv/TWiV. You can send us your questions and comments to twiv@microbe.tv. And if you like what we do, you can support us financially. Go over to microbe.tv/TWiV. And, we had said we're going to do picks of the week, but I keep forgetting. On Wednesday, we had a few. Brianne, did you add one here?
I did add one here.
Well, give it to us.
I just mentioned that Akiko Iwasaki has made an 8-minute video called Immunology for COVID, or Immunology 101 for non-immunologists. And it is a fantastic video explaining all the basics of immunology. For anybody who is trying to understand things.
Right.
So it's a really nice, well-animated, really lovely video.
All right. We have to get back to picks one of these days, for sure. All right. Brianne Barker's on Twitter, BioProf Barker, Drew University. Thanks, Brianne.
Thanks. It was really great to be here.
Dixon de Pommier, trichinella.org, thelivingriver.com.
Whatever.
I can never remember. Thank you, Dixon.
It's okay. Just type it out. They'll get it.
Thank you, Dixon.
Well, that's great.
Rich Conda is an emeritus professor, University of Florida, Gainesville, currently in Austin, Texas. Thank you, Rich.
Sure enough, always a good time.
My wife was watching some architecture show, and they were featuring, this is Impossible Engineering, that building in Austin that goes back and forth, the layers.
Jenga Tower.
Jenga Tower, that's right. Oh, it was so cool. And it reminded me of being there because I could recognize some of the places. That seemed so long ago. When would we go? Last summer?
It was before that.
Well, TWiV 500,
Yeah.
which was 2 years ago.
That's right, 2 years.
No, but
TWiV 500 was 2 years ago.
It's arcane.
But you were here since then because we went to Galveston together.
Oh, that was last fall. Yeah, that was last fall.
That was last fall.
Yeah, it's a great city. Too many, and they said 100 new people come a day. It's too many.
Yeah, one of these days I'll actually go downtown again.
What does the building do?
It's just the structure makes it look like at alternating levels the floors are I don't know how to describe it.
They're offset,
staggered.
Yeah, they're hanging over each other.
They're cantilevered.
They're cantilevered, and they say it's impossible engineering, but it doesn't look so impossible to me.
Even like the communications building in China is like that also, by the way.
Yeah. All right.
It looks like an Escher puzzle.
It's cool.
But it's not.
It's very cool. And the guy was describing, they had a local architect, and they were saying that, not too long ago, nobody was downtown, but all of a sudden the big techs moved in, and then people wanted to live downtown. So then they
naturally
built up. So anyway,
here, I'm gonna do this. I'm gonna share my screen real quick. Vince, Dixon, can you see it? See this picture?
Yeah. There you go.
Oh, I see it. It's like somebody put a bunch of blocks together and they were not exactly aligned.
Yeah. It's cool. So
for
those of you driving,
I like it.
For those of you driving, it's called Jenga Tower. It's probably not.
Yeah, look it up. Jenga Tower, Austin. You'll get it.
It's cool. Yeah, that's that block game where you put blocks on top of each other.
Okay.
I'm Vincent Racaniello. You can find me at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.